Hello everyone, I hope you all are doing great. I am Sabina, your mastermind faculty, and today we will be covering the one-liner of all the volatile topic of your fundamental of nursing subject, right? So before we'll start this video, I really need you to understand that this is whole soul, the video is for revision purpose, right? This is not for concept clarity, because uh, before I'll start, because this is very important point, I want you to understand that here we are going to revise all the one liner in a very quick and crisp manner, so that we can have our last revision, the last minute revision before our examination. Okay ji, so let us start the volatile topic revision of one liner of all fundamental of nursing subject. So let us start with the basics of infection, which is a very important unit, right? So under basics of infection, what is the important point that we need to remember is basically how many elements are there in a chain of infection. So yes, along with me you can say that there are in total 6 elements present in a chain of infection. How many elements are there? 6. Now quickly revise, what are those 6 elements? The first will be agent, which is the infectious microorganism or pathogenic microorganism. Second element will be the reservoir. Third will be portal of exit. Then after that, transmission, the mode of transmission, then portal of entry, and it will enter into the susceptible host. So in total, how many elements are there in the chain of this chain of infection? 6 elements, right? So there are 6 elements in the chain of infection. One point which is clear. Now let's move to the other point, which is the stages of infection. Right, question can be asked related to stages of infection. So the stage of infection basically start from the incubation state, which is the entry of pathogenic microorganism till the appearance of first sign and symptom. That is your incubation stage. Then move to your second, which is prodromal stage, when the body starts showing you the general sign and symptom, right? Then after prodromal comes your stage of illness, when the infection reach up to its peak, right? Its peak. Then after stage of illness comes the decline stage, when the body sign and symptom it is start declining. Then we'll move to the stage of convalescence, which is basically the stage of convalescence. It is considered to be the recovery stage, when the sign and symptom are subsiding, right? So how many stages are there? We have, first is the incubation stage, prodromal stage, then stage of illness, stage of decline, and the last one is convalescent stage. So these are 5 stages of infection that we need to revise. Another very important point, which is like one best one liner under infection control unit, is which is the most preventive, which is the most important nursing intervention in the hospital, which is used to prevent the risk of transmission of infection. And with your closed eyes, you can say the correct answer is hand hygiene. So hand hygiene is the first line intervention used to prevent or minimize the risk of transmission of infection. So we are done with this as well. We have revised the chain of infection and the element. Now let's move to another very important topic, which is hand hygiene. Under hand hygiene, the first and foremost part is related to the movements of hand hygiene. Let us quickly revise. How many movements are there? 5. And how to revise them? In a sequence. There are 2 before, 3 after. 2 before touching a patient, I have to perform hand hygiene. Before performing any aseptic procedure, I have to perform hand hygiene. And then after exposure to any body fluid, then I have to perform hand hygiene. Then after touching the patient, I have to perform hand hygiene. And the last after is after touching the patient's surrounding, right? So these are the 5 moments of hand hygiene that we should remember in the complete sequence. Now again, this is very important to revise the moments of hand hygiene in their exact sequence. Before touching a patient, before any clean or aseptic procedure, after body fluid exposure, after touching a patient, and after touching the patient surrounding will be at last, right? So we have revised the 5 movements of hand hygiene, which is basically tell us when the healthcare provider has to perform the hand hygiene, right? Now let us discuss a very important part, which is when do we celebrate the World Hand Hygiene and Global Hand Washing Day. So World Hand Hygiene Day is celebrated on 5th of May, and this is to be organized by World Health Organization. Remember, by World Health Organization we are celebrating World Hand Hygiene Day every year on 5th of May. And what is the theme of this year World Hand Hygiene Day? The theme was power of hand hygiene, right? So 5th May, every year we are celebrating World Hand Hygiene Day organized by World Health Organization. For 2024, the theme of this year is the power of hand hygiene. Now another very important event related to hand hygiene is Global Hand Washing Day. The Global Hand Washing Day, it is an international organization celebration which is to be observed every year on 15th of October. So every year 15th October we are celebrating as a Global Hand Washing Day, and this year the theme will be why our clean hands are still important. Do we need to remember and keep all revising the theme? The answer is yes. It would be great if you can revise the date and the theme both. You don't have to you don't have to remember and recall the theme of 2023. No, just remember the theme of this year along with the date on which date you are celebrating World Hand Hygiene Day and Global Hand Washing Day. Clear? Chalo, now let us move the very important part, which is the crisp one liner related to the hand hygiene topic. So the first is, what is the most important aspect of hand washing? Your answer will be, always remember, this is friction. So friction is considered to be the one of the very important aspect when you are performing, when you are doing medical or surgical hand washing. Now this is a very important question. What is the duration for soap and water? We know it is 40 to 60 seconds. What is the duration of alcohol based hand rub? We know it is 20 to 30 seconds. So when I am doing hand washing with soap and water, the time will be 40 to 60. When I am using alcohol based hand rub and performing hand hygiene, the time duration will be 20 to 30 seconds. What is the ideal concentration of alcohol solution that we are using for alcohol based hand rub? The range is 60 to 80%, but the exact concentration that should be there is 70% isopropyl alcohol, right? Again, let me repeat, the range will be 60 to 80% alcohol should be there, and exactly 70% isopropyl alcohol should be there in the hand rub solution. What is the duration for surgical scrubbing? Very, very important question for upcoming examination, and for this the range is 3 to 5 minutes. And if they ask you separately that for like one option has 3 minutes, another option they have given 5 minutes, then what to select? The correct answer will be 5 minutes, right? So the range is 3 to 5. But when the examiner will ask, because examiner are very smart, they can test your level of knowledge and understanding. So if they ask, if the question comes and where the options are having both this 3 and 5 unit, then we'll go with 5 minute, right? So 5 minute is the ideal time duration for surgical scrubbing. When the hands are visibly soiled, what to perform? So always remember, when your hands are visibly contaminated and soiled, then in that case we'll go with hand washing with soap and water. And when your hands are not visibly soiled, then you can perform hand hygiene by using alcohol based hand rub solution. But the very important point which we should remember and keep on revising this point is, in case if the question, the examiner can be very smart, because here they want to judge your basically they want to judge your level of knowledge, how much you have read the topic, right? So they can ask you this question, that if in case you are providing care to a patient who is admitted as a case who is infected with clostridium difficile. Now whenever you'll see this word clostridium difficile, we know we have to show the examiner that we are way more smarter than you, because we have already we have already made our concept very very clear, that if in case if the question, anywhere in the question, this word clostridium difficile is present, then in such cases the method of hand hygiene will be soap and water, right? No matter your hands are visibly contaminated or they are not visibly contaminated, the preferred method of performing the hand hygiene will be soap and water only, because the alcohol based hand rub solution is not that much effectively work if your patient is admitted or infected with clostridium difficile. This is the only point which we need to keep on revising under hand hygiene. Okay ji, so we are done. When hands are not visibly soiled, alcohol based hand rub. Routine method of hand hygiene, so as per World Health Organization, because for everything whatever we are doing, whenever we are touching the patient, we are doing anything, whenever you are following the movements of hand hygiene, so it is advisable when your hands are not visibly soiled, we can go with alcohol based hand rub solution, except the case except in case of clostridium difficile. So the routine method of hand hygiene as per the World Health Organization is alcohol based hand rub hand hygiene. How many steps are there? How many steps of hand hygiene are there? So in general, if you'll see a chart, there are lot of steps as per the World Health Organization. The standard chart that we have, it says that 11 steps are there, but no, the genuine steps of performing the hand hygiene, when you are doing the steps, that means when you are starting the friction of hand hygiene, so in total there are 6 steps. There are core 6 steps of hand hygiene, right? The best method to dry this hair, now make sure be very careful. This question is already asked in your NORCET 6.0, which is a previous year question. So the best method to dry the hand after performing hand washing would be, the preferred one is use of disposable paper towel is more preferred as compared to the use of drying the hand under hot air, right? So which one is more preferred? Disposable paper towel is more preferred. Now this is also we have covered, so we are done with the very important one liner of hand hygiene. Now let's quickly revise our medical and surgical hand hygiene. When it comes to medical hand hygiene, what are the important point number 1, always remember in medical hand hygiene how you have to when you are washing your hand after applying the soapy solution, how you have to wash your hand, what will be the position of your hand. So always remember, in medical hand washing, the hands are considered to be more contaminated. And remember the principle of cleaning, we have to whenever you are cleaning anything, we have to move from less contaminated towards more contaminated, right? So if I am saying that in medical hand washing my hands are more contaminated, and how I used to remember, the trick is, because medical hand washing commonly we are using to give oral medication, and oral medication you are giving with your hands, so hands should be more contaminated and it has to be washed thoroughly and properly. So in this way you can remember that when you are performing medical hand washing, hands are more contaminated. So that means when you are washing, once you are done with the friction and application of the soap, when you will start the process of washing, so your hand should be lower than the elbow, right? So you will start washing from the wrist then towards the fingertip, right? So water movement will flow from less contaminated, so the water movement will start from less contaminated towards the more contaminated region, right? This you need to remember. So in medical hand washing, come on, one more time, let us revise. In medical hand washing, once we are done with the application of soapy solution, we'll wash the hand from wrist to the fingertip, right? Because we want the water to flow from less contaminated toward more contaminated. We are done with this. Once we have washed our hand, how you will, how you will place your hand, above the waist level, below the waist level. So in medical hand washing, it should be below the waist level. Reason, quickly revise the reason, because we want, the hands are very contaminated, we want the water, because just after washing there might be possible the water droplet, our hands are wet, so we want the water to dribble from less to more contaminated area, right? This is also done. So we will keep our hand below the waist level after completing the medical hand washing procedure, right? Now one more point which is very important, whenever you want, after this point, when you will dry your hand with the help of disposable paper towel, always dry from fingertip. In case of surgical or medical, will dry from fingertip, right? This is also done. Now yes, this point is also clear. Let us talk about and quickly revise the surgical hand washing. So the time duration we already discussed, and we already revised that the time duration is 3 to 5 minutes, right? In medical hand washing, in surgical hand washing, as compared to the medical hand washing, hands are less contaminated as compared to elbow, right? So once you are after the application of solution, when you will start to wash your hand should be higher than the elbow. This is how you have to wash your hand. So the water will flow from less contaminated area to the more contaminated area. And once the washing is done, you will hold your hand, you will place your hand basically above the waist level. So I will place my hand above the waist level, so the when whatever water will be dribbling, it will dribble from less contaminated towards the more contaminated area, right? So this is also very important point. After scrubbing, after doing the surgical scrubbing, hold your hand above the waist level, and when you are washing your hand, the hand should be up than the elbow. Wonderful. So with this we are done with hand hygiene. These are the point which we need to revise. That's it. Now let us revise another very important topic, which is biomedical waste management. The first point that we need to revise is the IBQ question. Many times the question can ask you related to the symbol. What does the biohazard symbol look like? They can ask you this question. So always remember, this is your biohazard symbol. This is the symbol of, yes, very good, you all are very very excellent, I know you are pro now. So this is your cytotoxic symbol. And what is this symbol? Yes, absolutely, this is your recycling symbol. And this, where we have three leaves all together making a circle. Leaf means nature, so we want the waste to get dissolved in the nature, because this is biodegradable symbol, right? So this is biodegradable, cytotoxic, biohazard, recycling. This is not biomedical waste symbol. Please make sure, because they, examiner can put such option to confuse you, but the examiner doesn't know that you are way more smarter. Like I said earlier, that you are more smarter than examiner. You have already, you have already clear your concept, that will not call this symbol a biomedical waste symbol, will call it a biohazard symbol. Very good. Now in general waste, we do have a black bean, right, for general waste, because we know that under biomedical waste management we have only 4 category, which is red, yellow, your blue and your white puncture proof category. There is nowhere red bean. Red bean is used for where we are using the black bean. We are using black bean for the general waste. And again, in many cases, instead of black, you can see these two color, which is green and blue one. So green is basically to collect the waste, wet waste, and the blue is collect the dry general waste. So they both are used to collect the general waste, like paper, plastic, waste plastic likewise. Okay, so now let us quickly revise the important one-liner related to biomedical waste management. Number 1, which ministry is responsible for handling the biomedical waste management rule? Ministry of Environment, Forest and Climate Change. They can again put you and, to make you confused, they can add option like Ministry of Health and Family Welfare, in Ministry of Environment, Forest and Climate Change, World Health Organization, they can ask you. But we, like I said, you are very smart. You know the correct answer will be your Ministry of Environment, forest and climate change. When I talk about the biomedical waste bag, the bag it has, so basically the bag has a thickness of more than equal to 50 micron, and they should be non-chlorinated. This you need to revise. Come on, let us revise with me. The bag should be non-chlorinated and the thickness should be more than equal to 50 micron. Very good. Now another question that can be asked is where you are segregating the waste. As a nurse, this is the point where you are involved in the biomedical waste management. Other than that, our responsibility is finished. Our responsibility is to make sure the segregation should be very important, and our responsibility, because we all are very important, right? We should give ourselves importance. So as a healthcare provider, as a nurses, we are the very important pillar of a hospital, right? So your role begins when you have to segregate the waste, which is the first step of a biomedical waste process. So where you are segregating? At the point of generation, where you are generating the waste, that is the point where you are segregating into different color coding of the biomedical waste management, right? So it should be segregated at the point of generation. Then once it is segregated, it has to be collected by the housekeeping department, and if there is any waste which require pre-treatment within the hospital, then we have to send the waste for pre-treatment. But not all the waste require the pre-treatment. There are only selective waste, only selective. For example, the best example for this, which is important for you all to remember, is, let's take an example of blood bag. We have already discussed that blood bag should be discarded. This is a plastic material, is plastic. So this is the only plastic that should not be discarded in red, it should be discarded in yellow. We'll send this blood bag under a yellow color biomedical waste bag, and we'll send it to blood bank for autoclaving or pre-treatment, right? Similarly, if you have a vacutainer, such vacutainer with blood, somehow you have taken the sample and you forgot to send it to the lab. So what we can do now, the sample is of no use, we have to discard this sample. So in where to discard this sample? It has blood, so simply it has to be sent for pre-treatment under yellow color biomedical waste bag, right? So afterward they will take care what they have to do. Clear? So there are some ways that should be sent for the pre-treatment. So other than that, the housekeeping department will collect the waste that you have segregated while generating the waste, or the doctor will be segregating, right? So once they will collect, they will send it, and they will they will send in within the hospital. There is a storage room. There you need to revise one point, that no waste should be should be kept in the storage room for more than 48 hours, which is not treated, right? So we should not keep the untreated waste for more than 48 hours. Once the waste is collected into the storage room, within 28 yoga, it is 48 hours, right? So please kindly excuse me again, let us revise. We should not keep the waste for more than 48 hours in the storage room within the hospital premises, right? So we have to, from the storage room, it has to be shifted and transported to the place where the final treatment and disposal should be done. And what is the name of that place where the final treatment and disposable process should be taken care? Is basically the common biomedical waste treatment facility. So this is the site or place where your final treatment is going on, right? So no waste should be kept untreated under the storage for more than 48 hours. This we need to remember. Now this common biomedical waste treatment facility, it is important that this place should be within the 75 kilometer of distance with the hospital. Another very important point, next, the very volatile point related to the biomedical waste management is, what is the final treatment of blue bag, yellow bag, red bag, and white puncture proof container? Do I need to revise this? These are highly important, this you have to, there is no way you can skip this. You have to revise, means you have to revise. And it would be great while sleeping, if you, whenever you will get up with the tension, you can revise these points. So always remember, the final treatment of yellow color coding biomedical waste bag is incineration and deep burial. This is the only This is the only biomedical waste bag whose treatment is to burn the waste, or we can deep burial the waste, right? So incineration or deep burial. What is the final treatment of red color biomedical waste bag? Is autoclaving, send for recycle. What is the final treatment of blue color? Autoclaving or disinfection, then send for recycling. What is the final treatment for white puncture proof container? It is dry heat sterilization. Remember, dry heat sterilization or autoclaving followed by shredding in a small pieces. We have to cut the waste which we are discarding in a white puncture proof container. After this we'll discuss that what we can discard, right? So these are the important point. Now let us quickly revise before this, that what we are discarding. In yellow we know that all the all dressing, all the linen, all the infected material we will be discarding in the yellow biomedical waste bag. Red will be all contaminated infected plastic, tubings, catheter, syringes, glove, whether they are contaminated with blood or not, we have to discard in red bin. All form of catheter except the blood bag. All form of catheter. IUD is also we are discarding in red bin, right? Blue, there are two category in blue. One category is the container where we are discarding all the glass item, broken and unbroken vial, ampule, every glass item should be discarded in blue color bag. Then another blue is for implant, the surgical implant, right? The ortho implant. Once you have a patient and admitted for a removal of nail, the procedure is done. Now the family doesn't want to take that implant, so you have to discard it. Where you will discard? Simply in the blue color biomedical waste where we are discarding the implant. Then we have a very sweet and simple puncture proof container, which should be, it is basically we do have a portable puncture proof container. As a nurse, this is your responsibility to make sure that every patient bedside puncture proof container should be available, so that you can discard the sharp then and there, and you can prevent yourself from the exposure of needle stick injury, right? So sharp, the white puncture proof container, basically we are discarding everything sharp item like needle, stillet, suture needle, everything which is sharp should be discarded except the glass material. The glass should be discarded into the blue bin, right? Another very important question is when to, this is a question for revision, is when to empty these biomedical waste bag. Like we know that under the process just now we have revised, housekeeping staff will come and collect the waste. So when actually they will come and collect the waste? When we are replacing these biomedical waste bag. So when they are, always remember, when they are 3/4 fill, when they are 70% or 75, when they are 75, when the bag or the puncture proof container is 75% fill or 3/4 fill, and that is the moment when you have to replace. Because otherwise, if a puncture proof container is there and all the IV stillet is there and needle is there, if you keep on filling that puncture proof container, then there will be one moment that no space will be left in that, and when you are trying to discard any sharp item, you can expose with the infected needle, right? So always remember 75%, or when it is 3/4 fill, we have to replace it. Now let us quickly revise the important one liner related to incineration or deep burial, which is your final treatment for yellow color biomedical waste bag. So incineration is it is basically, what is this process? This is, remember, it is high temperature dry heat oxidation process. And when I say oxidation, that means the burning is happening with the presence of oxygen, right? It is dry heat oxidation process at high temperature. Incineration, it basically the machine, the whole the place, the machine has two chamber, primary and secondary chamber. The temperature that we have to maintain in the primary chamber is somewhere around 800 degrees Celsius, and the temperature that we have to maintain in the secondary chamber is somewhere around 1050 plus minus 50 degrees Celsius, right? Now there is a stock to let the gas, to let the fumes go into the atmosphere. So this is important, that the stock height should be 30 meter above the ground. It should be 30 meter above the ground, so that we'll try our best to minimize the air pollution. Okay ji. Under deep burial, what are the important point? For deep burial, we have to make sure the pit, the trench should be minimum 2 meter deep. It should be 2 meter deep. Then you have to half fill the this pit with the waste, and then you have to spread a layer of lime of 50 centimeter, then cover it with the soil. So whenever you are adding the waste into that pit, you have to you have to cover it with the soil as well. Okay, and of course we have to make sure that that particular land which is used for the deep burial purpose, it is not easily accessible for should not be accessed by the people or by the animal. Okay, it is a complete government property. Now let us quickly revise another important point related to the biomedical waste management, which is disposable of personal protective equipment. So let us revise these from head. We have a head cover should be discarded in yellow. Then the face shield in red bag. This on this side I have yellow, on this side I have red, right? So because personal protective equipment we cannot discard in in blue or white puncture proof container, which is very self understood, right? So either will discard in the yellow, which is here you can see I'm wearing this yellow, so yellow is this side, red is this side, right? So head cover will discard here on my right, yellow. Then face shield, right, red, head cover in yellow, face shield in the red bean, goggle in the red bean, then mask, whether you are wearing surgical mask, N95 respirator in the yellow bean, right? Then comes your gown. So if you are wearing surgical gown, coverall suit, isolation gown, in the yellow. If you are wearing the plastic apron, which is usually used by the the scrub nurse or the scrub surgeon before the surgical procedure, when there is a risk of high body fluid exposure, right? So plastic apron is like a sheet to protect the clothing which they are wearing, not to get moist, not to get exposed, right? So plastic apron should be discarded in yellow bean. Then comes your gloves, whether they are contaminated with blood or they are not contaminated blood, even after after using, you have to discard in red biomedical waste bin. So gloves in the red. Then comes your shoe cover. Shoe cover should be discarded in yellow biomedical waste bin. So this is how you have you have to revise, which is very very important. Chaliye, so we have a list of the items that we usually use in our day-to-day nursing practice in the healthcare setting. Let us quickly revise that where to discard. So remember these points: plaster cast, placenta, cotton dressing, gauze, bandage, soiled linen means bed sheet, mattress, anything, any form of linen, any form of clothing, chemical solution, expired medication, live vaccine, alcohol swab, pathological waste, and blood bag. So these many items where you will discard, these are the most common one that I have selected here on my screen, which you can see in the yellow biomedical waste bag. As simple as that. Then on the other side you can see all the lines and tubing, the plastic material, euro bag, CVP line, NG tube, Foley's, IV catheter without the stillet, right? Then BT set, not the blood bag but the blood transfusion set. Here let me make your point clear that as per AIIMS, they have mentioned in their guideline that blood bag they will send it to the blood bank in a yellow bag, but BT said one can discard in red, right? So IV set, TPN bag, gravity bag, gloves, syringe, vacutainer without blood. So these are basically vacutainer, but this is with the blood, right? So with the blood it has to be pre-treated, will send in yellow. So if you have a vacutainer without blood and they are just get contaminated, that you can discard in red. Then IV bottle, plastic one. So this all will be discarded in red biomedical waste bin. Then we have IV stillet. Once your IV cannula is inserted, the stillet, the sharp one, should be discarded in puncture proof container. Needles, sharp blade, surgical blade, suture needle, and we do have syringes with with which the needle is attached and that cannot be detachable. For example, insulin syringe. When I say insulin, always remember it is U100 unit. which is commonly used nowadays, right? So this all will be discarded in white puncture proof container, very sweet and simple one. Then the last one is the yellow, which where we are discarding all the ampule vial. So previously we have this practice that the ampule after using it will become a sharp. So don't have this thought that it is a sharp, it should be discarded in puncture proof container. No, all form of glass, whether this is broken or non-broken, broken, should be discarded in the blue biomedical waste bin, right? And then lastly we have implant. Chalo, let us quickly, now this is your question to judge your knowledge, like we will be having in your NORCET examination. This will be discarded in yellow because I know you all are smart. So here you can see the glove which are contaminated, visibly soiled or contaminated with blood. But wait, I know you all are very smart. You will not tell me that this will be discarded in yellow just because you can see blood on it. No, it will be discarded in red because you all are pro, right? So this is your N95 respirator in yellow. This is an implant which will be discarding in blue. Okay, so with this we are done with biomedical waste management. Move on to the next topic, which is standard and transmission based precaution, right? Again, another very important precaution, another important topic. When I say standard precaution, always remember these are the basic intervention or precaution that should be applied to all the patient irrespective of their blood pathogenic infection, right? Because earlier the standard precaution are basically was called as universal precaution, and you all know that universal precaution is only applicable to patient who are infected with any blood-borne pathogen. And when I say blood-borne pathogen means whether they are infected with HIV, hepatitis B virus, or hepatitis C virus. And always remember the rule of 3: 30%, then 3%, then 0.3% is it is the chances that patient can have, right? So if now the concept has changed, right? Now there is the concept of standard precaution. Whether your patient is HIV infected or your patient is not HIV infected, we will apply the standard precaution to everyone because we believe in equitable distribution of care. We'll treat the patient as an individual and will provide, will give justice, will give equal justice to everyone, right? Okay, now what are the elements comes under standard precaution? The elements that comes under standard precaution is your hand hygiene, right, which is very important, personal protective equipment, respiratory hygiene and coughing etiquette, prevention of injuries from the sharp, safe handling of patient equipment, which is we need to make sure it should be properly sterilized, it should be disinfected, principle of asepsis, and at last the environmental infection control. Patient placement, patient should be placed as per their the infection they are infected with. If the patient is infected with the airborne transmission of infection, then we have to place the patient under airborne precaution. So these are the standard precaution element. Do I need to revise this? Do I need to remember this? Answer is yes. Yes, this we have to. Because this much we can do. If we need to clear the NORCET with a very good score, thoda to karna padega, right? Now let us quickly revise the type of precaution that should be applied to the hepatitis family. Now we all know that in hepatitis we have a lot of member. We have hepatitis A, B, C, D, E. Right? Commonly hepatitis A to E. So how many member are there in hepatitis? We have A1, 2, 3, 4, 5. So in total we have hepatitis family has 5 member. Now always remember, let us revise this with the mode of transmission. We know hepatitis B and C are transmitted through the blood route, right? Through the blood route. So hepatitis B and C and the D1 also, it is also transmitted, and it is important that it is transmitted especially if in case patient is having hepatitis B. So all these hepatitis B, C and D, they require standard precaution. We don't have to put these patients into any form of transmission precaution. Only standard precaution should be maintained for hepatitis B, C and D. Now what about the elder one and the youngest one? So in any family, the elder one, the elder child, and the youngest child, they are the two who require more attention, who need more attention, right? So younger one should be the one who who is always like who is very disciplined one and the loved one, Later on, the elder one should be the disciplined one, and the younger one is the is like a very naughty type of child, right? So the younger one, it should be very disciplined. That means we need some type of precaution. So the elder one. So the elder one is your hepatitis A, right? Hepatitis A. So hepatitis A and E. Hepatitis A is the elder one, hepatitis E is the younger one. Both the route of transmission of infection is fecal oral route, right? Because they are the one which they are more loved one, you can say that. So hepatitis A is more discipline. So discipline requires some precaution, then only you will get the discipline. So in case of hepatitis A, remember this, in case of hepatitis A infection, if this hepatitis A patient does not have any form of incontinence, or in case of child, right, if there is no use of diaper, so if the patient is having incontinence or child is on diaper, if in case of baby is having hepatitis A, or if an adult patient who is having hepatitis A, who is having incontinence of stool or incontinence of stool, then in that case only we will put the patient on contact or standard. Let me repeat, if you have a patient who is having an infection of hepatitis A, if the patient is not having any incontinence of stool problem, right, of the or the baby, or you are not dealing with the baby who is on diaper, then you have to apply only standard precaution, right? But if your patient is infected with hepatitis A, and patient is having, along with hepatitis A, patient is having incontinence of stool, or maybe the baby who is, you have to put him on diaper, then in that case you are handling, if whenever you are handling the stool, so make sure you have to put the patient on contact precaution, right? Other than that, for everyone, standard precaution. Only there is one case where you have to put the patient on transmission based precaution, which is the elder one, because they have to be they are the one who are more disciplined. So the elder one is hepatitis A, but there is only one condition, the hepatitis A with incontinence only, which should be put on contact precaution. Other than that, all are on standard precaution. Right now, there is a very quick and easy mnemonic you can remember for contact precaution. It is Mrs. V. Under Mrs. V, what point we need to remember is multi-drug resistant organism, which is very important. Under multi-drug resistant organism, vancomycin resistant enterococci, then we have methicillin resistant staphylococcus aureus. Very important, very important. Many time question can ask that if your patient is infected with the methicillin resistant staphylococcus aureus, where they can, the organism usually present in the nasal cavity, they develop their colonies and their entire home in the nasal cavity of the patient. So which precaution you will apply to this patient? Contact precaution, because they are come under multi-drug resistant organism, right? Then in case of varicella, scabies, diphtheria, we will be applying precaution to contact precaution. One more point, in case of clostridium difficile, this you need to remember. So these are the 2 points only which you can remember: clostridium difficile, contact precaution. In case of multi-drug resistant, contact precaution. Then droplet. Under droplet, what are the important point? The mnemonic is Spider-Man. But what are the important condition which usually asked in question is diphtheria, bacterial meningitis. Mark this word, diphtheria, bacterial meningitis, epiglottitis, scarlet fever, they can ask you, pneumonia, parvovirus, and they can ask you influenza, right? So pertussis, diphtheria, and this mumps, not measles. Measles is the one where we should not provide droplet, right? Diphtheria, pertussis, mumps. We know diphtheria, pertussis, measles. We usually used to remember like this, but no. In case of transmission precaution, diphtheria, then pertussis and mumps. You can have influenza, epiglottitis, bacterial meningitis, and scarlet fever. So these are the conditions which you can remember where we have to put the patient under droplet transmission precaution. When I say droplet, always remember the droplet, here the respiratory droplet size will be less than, the respiratory droplet size will be more than 5 micron, right? Because they are heavier in size, so they tend to fall down over the surface. Then last but not the least, very easy to remember, the mnemonic is MTV. M stands for measles, T stands for tuberculosis, Mycobacterium tuberculosis, and V stands for varicella zoster or herpes zoster. So these are the condition where we have to put the patient on airborne transmission precaution, where the droplet nuclei. So here the respiratory droplet, we call it as droplet nuclei because of their size. It is less than 5 micron. Right, they are very small in size, though they will remain in air for a longer period of time. This is the reason airborne transmission of infection is not come under direct transmission of infection. It does not come under direct transmission of infection, right? So remember this. So now one more very important point is, we have revised that what all important condition infection are there where we have to put the patient on droplet, airborne, or contact precaution. Another very important point, when I say contact, airborne, and droplet, what are the important points? What are the elements are there? So always remember, in all these three precaution, along with this we have to apply standard precaution, which is mandatory, because standard precaution is the basic one that should be followed in all the patient. Along with standard precaution, when I say contact precaution, what is the mandatory personal protective equipment that should be used whenever you are providing direct care to the patient? So always remember, gown and gloves. So gown and gloves should be wear mandatory, and it is possible, if it is possible, you can give single room to the patient. Other than that, we can shift the patient to the cohort isolation. And again, revise, what do we mean by cohort isolation? Means we have to, the patient with the similar infection are placed in one room. That is cohort isolation. Then one more another point, let us revise, what should be the distance between the bed of two patient? Minimum 3 feet, right? It should be minimum 3 feet. In case of droplet, what are the mandatory personal protective equipment that should be used by the healthcare provider? Is surgical mask. For airborne it should be respirator. Another question that can be asked, that you are a healthcare provider, your patient is on airborne precaution, so you will be wearing respirator. When you need to transfer your patient into any other area of a hospital, let's take an example, for x-ray you have to transfer your patient, or for any other radiological investigation. So which personal protective equipment you will you will put the patient? So you will ask the patient to use surgical mask, not respirator. As a healthcare provider, you will use a respirator because you are protecting yourself by filtering by filtering out the more air without this microorganism. Okay ji. Now what is the, let us quickly revise the concept of reverse isolation. So reverse isolation is used for the patient because here the patient is immunocompromised, the patient is at high risk for getting the infection from ourselves or from the hospital environment. So usually we have to place such patient under positive pressure room, right? And for airborne we have to place such patient under negative pressure room, right? So negative pressure room, reverse isolation used for the patient to protect themselves, like transplant wale patient and patient those who are immunocompromised, they can easily catch the infection, so we can place such patient under positive pressure room. Now in the time of COVID, the World Health Organization has released a list of procedure that that are involved in aerosol generating. So for, if you are involved in any of these procedure and if your patient is in airborne precaution, then make sure wear N95 respirator, right? N95 respirator, for example, endotracheal tube intubation, bronchoscopy, cardiopulmonary resuscitation, giving prone position to a mechanical ventilator patient, and performing open suctioning. So all these procedure considered to be aerosol generating. Aerosol means droplet nuclei that can, it is basically under the mode of transmission of airborne. So this is all about your transmission and standard precaution. Now let us quickly revise healthcare associated infection. This is also very important. The first and foremost healthcare associated infection, before this we should know how many names are there, because there are so many names healthcare associated infection are called. They earlier, the traditional name is nosocomial infection, then we have hospital acquired infection, then now at present we are calling it as healthcare associated infection, which is not present, the infection which is not present at the time of infection, at the time of admission, and patient will get this infection during the hospital stay, right? During the hospital stay. Now this is what you need to revise and recall. So, what is the most important criteria for a healthcare associated infection? Number one, the infection should not be present at the time of infection, and you will get this infection after being admitting and receiving the treatment from the hospital after 48 hours. Criteria number one is you will develop the sign and symptom of infection, and the infection start appearing after 48 hours of admission. Number two, your discharge is over after 3 days. After 3 days of discharge, if you will, if you will develop any sign and symptom of infection, that will also consider as healthcare associated infection. Now in case of surgery, there are 2 points. Your surgery is done, you have you got the discharge. After 30 days of surgery, if you develop a sign and symptom of infection, that is also considered as healthcare associated infection. But in case if you have a surgery, if you have undergone a surgery which is having implant in place, if in a surgical procedure where implant has been inserted, and under this condition only, if a patient develop any sign and symptom of infection within 1 year of surgical procedure, then in that case also will consider is at healthcare associated infection, right? So these are very important criteria. Again, let us revise. The first criteria is the infection is not present at the time of admission, but will developed after 48 hours of receiving the care. Then criteria number one. Second is 3 days after the discharge, if patient showing any sign and symptom of infection, this is also a healthcare associated infection. Fourth one and the last one is after surgery, 30 days of after surgery, then also we are considering. And if the patient surgery involved the implant, any implant insertion, and if patient developed sign and symptom of infection within 1 year of surgery, then also it is considered as healthcare associated infection. Very good. Now let us quickly revise the last minute pointers of healthcare associated infection is which one is the most common. So of course COTI. We do have how many type of healthcare associated infection we have? COTI we have CLEPSI, we have VAP, and we have आपका SSI. So COTI is catheter associated urinary tract infection, CLEPSI is central line associated bloodstream infection, then we have आपका ventilator associated pneumonia, and the last is the surgical site infection. So surgical site infection is the most expensive healthcare associated infection. I know you can understand, because a lot of surgical intervention were involved in this. So the most common among these is, no doubt, yes, you all are very smart, I know, this is COTI. The most common microorganism responsible for overall healthcare associated infection, the answer will be Staphylococcus aureus. It is not E. coli, it is Staphylococcus aureus. The first line intervention to minimize the risk of infection. Now this I already discussed when we are beginning the session, and you all are very intelligent, you know the answer, right? Which is hand hygiene. The care bundle. So in order to minimize the risk of development of these nosocomial or healthcare associated infection, we do have a checklist which is called as care bundle. So COTI care bundle, CLEPSI care bundle, VAP or SSI care bundle should be used in the clinical setting to minimize the risk of hospital acquired infection, right? Now let us move to next topic, which is your personal protective equipment. Now under personal protective equipment, the doffing and donning method, I'm sure you all are very well aware about. Tell me quickly, what do we mean by donning? Very good. Donning is wearing a PP, doffing is removing of PP. Very good, right? So when it comes to doffing of glove, when you need to remove the glove, there is one practice that needs to be followed. And what is the principle of doffing of glove says that we can go with skin to skin and glove to glove. Whenever you are removing the glove, always follow this principle, skin to skin and glove to glove, right? And another very important point on which which glove which in which hand you will wear the glove first, and in which hand, from which hand you will remove the glove first. So always remember, when you are wearing, we have, as a being a human, it is our tendency that whatever we are doing it whatever we are doing it first with our dominant hand. In this way you can remember. So you will, and most commonly the dominant, in majority of population, the dominant hand is the right hand. So right, we will wear the glove in right hand first, which is a dominant hand. And when it comes to doffing, will basically the doffing should be done first in your non-dominant hand, right? Now let us quickly have IBQ session, very important. Yes, this is your respirator. Yes, very good, that we are using in airborne transmission based precaution. And this is your surgical mask that you all know, and that we have used under the droplet transmission based precaution. Surgical mask, what is the other name of surgical mask? Yes, tell me, what is the other name? It is triple layer mask. Now let us quickly revise the respirator. The most common respirator, that we are using in clinical setting is N95. And remember, the respirator without exhaling port are the good one to use in clinical setting. So N95 respirator is the most common one. But what is the full form of N95? So N is an alphabet, 95 is a numerical value. N means it is a non-resistant to oil based particle. N stands for not resistant to oil based particle. 95% is the percentage it can filter out the airborne particle, right? So it can filter out 95% air particle. And N means it is not resistant to oil based particle, right? Now next, come to the donning and doffing of your respirator. When it says donning and doffing, what question can be asked in your NORCET? They can ask you that if you are wearing a respirator, then which strap? It has two strap. Respirator has two strap. If you can see here, the top strap and the bottom strap. Let me highlight the bottom strap with other color. So the top strap I have highlighted in pink color, bottom strap I have highlighted in green color. So there are two strap. Question can be asked in this way, that while performing the donning, which strap which strap you should use first. So always remember, when we are donning or wearing the respirator, will always use the top strap, the pink one, the top strap, and then later on we'll use the bottom strap, right? This is sorted. For while wearing, use top strap first. When it comes to doffing, now our procedure is done, right? So let's go step by step so you can have a better revision. You have to wear a respirator. Before wearing a respirator, of course, you will perform hand hygiene. Then you will take a respirator, you will put the respirator in your palm, and then you will put the respirator on your face, make sure covering the nose, entire nose, mouth and chin. This is the way you will hold the respirator. So respirator has two straps, the top one, the bottom one. So first, while wearing, I will use the top. I will take the top strap and take it behind my ear to the crown area, not go beyond the neck, right? Not go beyond this. I will not take the top strap to my neck area. I will take the top strap till my crown area, and then after that I will take the bottom strap, and then I will put it I will keep the bottom strap below my ear and under behind my neck, right? Below my ear, not above my ear, right? This is how I will wear my N95 respirator. After wearing the N95 respirator, I have to make sure, that this respirator has a molding, aluminium mold, right? It should not be on the basically on the downward side, and then the strap should not do any crisscross, and I should not put the respirator under my neck. So these are the method which I have to focus. Once the respirator is done, wearing process is done, After that, I have to make sure that this respirator is completely providing me a complete seal, and in this way, and it is, it is of appropriate use. So how I can make sure? By using two tests, fit and seal check. How I will make a fit check? So like I said, that this respirator on the top has an aluminum mold. I just have to mold it, press it, and make sure that it will exactly, that it will make a shape of my nose, so it can, it can make, it can provide a proper fit, right, as per my facial structure. Then second will be the seal check. Seal check should be performed in two ways: negative pressure, positive pressure. Why I am performing seal check? To make sure no air will get leak. If I am having a leakage of air, then the mask will not work properly, right? I cannot, it will not able to filter out the airborne particle. So how I will do this seal check? I have to use my hand, place it over the respirator. Then once I'll place it over the respirator, I will inhale. When I'm inhaling, of course I am generating a negative pressure. So when I'm inhaling, this respirator will bulge inward, right? The respirator has to move inward with the pressure, with the negative pressure that you are creating, and with no leak in the surrounding area. And then I have to perform after that positive seal check. For positive seal check, I have to blow out, right? I have to exhale out. When you are exhaling out, the respirator has to move, bulge outward, right? So you can feel that respirator is moving out and no leak, no air is getting leak. This is how you have to perform the seal. This is your fit check. Here you can see, and this is the seal check that you have to perform. Once you are done that both the test is okay, then you can use it, and you can perform, and you can, perform your duty, and you can wear it till your one shift duty, 8 hour shift duty or 12 hour shift duty. Once your duty is over, once your entire shift is over, then I have to remove this respirator. Where I will discard it? In the yellow biomedical waste bin that we have, while we are practicing. Now how I will discard? Of course, before discarding, I will perform hand hygiene. Now here you need to remember, because now this mask, the front side is exposed to a lot of microorganisms, so do not touch the respirator from the first side, from the front side. Do not touch it. How you will remove it? First, what you will do while removing, you will use the bottom strap. Take the bottom strap first, and then take out the top strap. That's it. Don't touch the respirator. The only thing that you can touch is the strap. So first one is the bottom, and the second strap that you will remove is your top strap. This is how you will remove and discard it in the yellow biomedical waste bin. So make sure that no air should leak when you are performing the negative and positive a seal check. Very important question. Let us quickly revise. What is the first step of donning of personal protective equipment? The first step always remains your hand hygiene. You have to perform hand hygiene, then only you'll do other step. What is the first step in doffing? Now here we are, removing the personal protective equipment. Though the first step of doffing will always be glove, right? And this is the sequence which we quickly revise as per the Center for Disease Control. So when it comes to donning, and again let me tell you, these are the sequence for aseptic clean procedure, not for sterile procedure, right? So first we will wear gown, mask, goggle, at last glove. First is gown, then second one is the mask or respirator, then goggle, and then glove. When it comes to doffing, removing, first thing that we will remove is the glove, followed by, after removing the glove, followed by goggle, then gown, and at last we will remove mask, and then we'll perform hand hygiene lastly, right? So under doffing, the first thing that we are removing is the glove. Under donning, the first thing that we are doing is hand hygiene. First step will always be hand hygiene. Okay ji, so we are done with the personal protective equipment. These are the volatile topic under infection control unit. Now let's move to other topic of fundamental of nursing. So another topic is your crutch walking. Now crutch walking is very important because we have a previous year question as well. Let us quickly revise. So crutch walking means you are using the crutch. What will be the size of crutch? How you have to hold it? Always make sure the appropriate length of the crutch, we can say, when there is a distance of 1 1.5 to 2 inches from the axilla. So what is the ideal distance from the axilla till the crutch pad? These are the crutch pad. It should be 2 to 3 finger, or you can say 5 centimeter below the axilla, or 1.5 to 2 inches. Let us quickly revise in fingers, 2 to 3 finger, or there should be distance from the axilla till the crutch pad. It should be 5 centimeter distance, 2 to 3 finger distance, or 1.5 to 2 inches distance should be there. The axilla pad should not be directly touching the axilla. The crutch pad should not be directly touching the axilla. There should be a distance between the crutch pad and the axilla, right? When you are holding the crutch pad, what should be the angle of your hand? Your hand should be flexion at the elbow joint, right? So hand is flexion, the basically you have to hold your hand in flexion movement at the angle joint, and making an angle of 15 to 30 degree. So 15 to 30 degree flexion should be there at the elbow while you are holding the crutch. This you need to revise. Now another very important point of revision is where you will hold the crutch if in case you have to use only one crutch, or if you are using a cane. So if you are using only one crutch, or if you are using a cane, always remember they can, all should be hold. You can, if you are using a cane, if you are using only one crutch, always hold on unaffected side or strong side of patient or unaffected side. This is mandatory, and this is 10-star question, right? If you are using only one crutch, if you are using cane, I'll show you the image. This is how the cane look like, the chhadi. If you are using cane or only one crutch, then hold it on stronger side or unaffected side, right? Do not, always remember, in case of crutch, do not put the body weight on the axilla, because there we are having rich blood supply, so we don't want to get damaged with the pressure. So do not put the pressure on the axilla. The next question, where we are putting the pressure? On the palm. With the palm we are holding the crutch handle. That is the point where you are putting all the body weight, right? Now let us quickly revise the crutch walking gait. We have 2.34 swing to swing through gait. These are very common. Under 2 point, the point that you need to remember and revise is you can put partial weight on the affected leg, right? Touch down, that means the affected leg is touching the surface, and putting the on that affected leg you can put some partial weight, right? You can put some partial weight. So how you will move with the second, with the 2-point gait technique? One is you will, you are holding, your patient is having crutch on both the sides. So let's take an example. This is my right side and right leg is affected, but I can put the right leg on the surface with some, I can bear the weight as well. So first I will move the left side, first I will move. So again, let's start with the scenario that right side, my left side, because here on the screen you have left side, so you can correlate. So my left side leg is affected, but I can touch, I can place the leg on the surface, and I can bear some body weight. Okay, and I am having crutch on my both side, left and right. So which point we will move first? Always move crutch first. So I will move crutch from which is on the affected side. So I will move left side crutch, along with left side I will move opposite side leg. One crutch, one leg at the same time, right? So 2 point is you are basically putting 2 point on the ground, on the surface simultaneously, which is one crutch, one leg. And which crutch should be moved first? The affected side crutch. So left side is affected, I will move left side crutch. Along with left side I will move I will move right leg. So left crutch, right leg. Then second may right crutch and affected leg, which is left leg. This is how you have to move. Then 3 point is very, very important, because many times they can ask you this in question. 3 point is the only gait that you can use when you don't have to put the leg on the surface, and you don't have to put any form of weight on that particular leg, on that particular extremity, right? So this you can use in case of amputation, in case of fracture, where you don't want to put any form of weight on that particular, on that affected leg. So let's take an example. Here we are having right leg fracture. So right, if you are having right leg fracture, how you will move? You will move both the crutches forward, the right and left side, and along with these crutches you will move your affected leg. As simple as that. Both crutches, right crutch plus left crutch plus affected leg, which is your right leg. You are moving all these three together. This is the reason they are called, it is called as 3-point. Right crutch, left crutch along with the affected leg, because we don't want to put that leg on the floor. So with both the crutch we have to move together. We have to put the entire body weight on the crutch to move forward. Okay ji, so this is your 3-point. 4-point we can use when we have, we need to maintain some balance and coordination. For example, after amputation, you have a patient. Now patient has got a prosthesis implant, right? So after that, patient start learning how to walk with the prosthesis, with that prosthetic implant, right? So that time we can use a 4-point gait, where we need to use it more coordination, balance, right? If your patient is having poor balance and muscle weakness, then this 4-point gait is good to use. What we are doing is we are moving step by step, one foot, one crutch or 1 foot at a time, right? So what we can do, we can always start with the affected side crutch first. So first is left crutch. Let's take an example. Your left patient, left leg having muscle weakness. So first is left crutch, right? So left leg crutch, then right side leg, then आपका the next is left crutch, right leg. So 1 point at a time, 1 point at a time, 4-point. Now swing to and swing through gait can also use when you have to put limited weight on the extremities, on the lower extremities. Swing to means first you have to take both the crutch forward at this point, then you have to put your entire body weight on these handle, and then while putting the body weight you have to swing your body up to this point where you have holded the crutch, where your both crutch surface, both the crutch point present on the surface. That is swing to. Now swing through means you have to again take both the crutches forward, like here you can see in this image, both the crutches forward, then put the entire body weight. Once you have put the body weight, then you have to lift your lower extremities and swing. And now here in this swing through, you will not put both the leg at this point where your both the crutch are present. You basically swing and through. You will place both your leg a bit forward than both the crutches on the surface, right? Basically both the leg forward past the crutches. This is your swing through gait. Now another important point, when you are using a cane, how you have to move on the stairs and get down from the stairs. What are the point? So when you are descending, you are descending the stairs and ascending the stair. Descending the stairs, always remember the mnemonic. Whenever we are going down, we will go down with the bad memory. Whenever you are going down, you will go down with the bad memory or bad people. Whenever you are going up in your life, you will go up with good memory, with good memory or good work, right? So good memory or good work means, here I mean to say, whenever you have to climb the stairs, you are climbing first with the strong leg which is not affected. So step up with your unaffected leg, which is strong one, or your good leg. Now again, let us quickly tell me where you are holding the cane, on the affected side or unaffected side. On your unstronger side, not on the affected side. This is my weak side, but here I am not holding the cane, I am holding the cane on the unaffected side. So this is how you have to move. I am holding the cane on the unaffected side, and when I'm ascending the stairs, I will always go up with the good leg. So unaffected leg first, then cane, then affected leg, right? This is how I have to move. First आपका जो है क्या आएगा, first is your good leg, then cane, then your affected leg. Then when I am coming down from the stairs, so if you are coming down from the stair, then you have to go down with the bad memory one, which is affected leg. So first you will place cane, followed by your affected leg, then your unaffected leg or strong leg, right? This is how you have to use the crutch on cane. Always remember the appropriate height of the cane. Make sure the patient is wearing the shoes when you are measuring the appropriate height of the cane or crutch. Then this groove, it should be at greater to ventral level, right? Okay, so these are done with the crutch. Then move to the next volatile topic, which is restraint. Very quick, let us quickly revise the restraint. Number 1 point, restraint should always be used as a last resort, should not be the first option. As a last option we have to consider, and used as a least priority, right? Once the doctor has written the order of restraint, the written order is valid only and only for 24 hours. Once the 24 hour is over, and if your patient require further restraint also, then doctor has to make a fresh order for the restraint application, right? Another point, if you have taken the verbal order of restraint from the doctor, then you have to make sure as a nursing responsibility that doctor has to come and write the order as soon as possible or within 12 hours. Okay, seclusion, we have three type of restraint: physical, chemical, and environmental. The environmental restraint, the term that we use is seclusion. Do not provide seclusion and physical restraint together. Very important point. Once your patient is on restraint, you have to assess the patient every half an hour for circulation, for nutrition, for elimination need, for the skin of the patient. So every half an hour you are assessing the patient condition who is on restraint, and every 2 hourly you have to perform a restraint release trial to assess whether the patient is fine now, whether your patient is further need whether there is a need of restraint or not. So every 2 hourly you are assessing a patient for restraint trial. Every half an hour you are assessing a patient for general condition, whether it should not be like that you have tied the restraint too tight that the circulation get compromised. So whenever you are tying the restraint, it should be 2 finger loose. Now where you will fix the restraint, always remember, not on the bedside, on the bed frame, right? Yes, we are done, and restrain release style we are done. It should be 2 finger loose. The most common restrain IBQ that one can ask in your competitive examination is this one, that is your mitten restraint, where we can commonly use mitten restraint in a combative or volatile patient who are trying to remove their important or vital lines and tube like IV cannula, ET tube likewise. So you can use mitten restraint, and these are under the category of least restrictive restraint. What is this? Least restrictive restraint. Now what do we mean by least restrictive? Means these are that form of restraint where we can have minimum restriction of the movement of the patient, right? Now another point is primary and secondary survey, a very volatile topic because many time question have asked on primary survey. So under primary survey the mnemonic is A B C D E, but here A B C D is not apple, ball, elephant. No, the A B C D in our profession we always remember as A stands for airway with, whenever you'll remember, you remember it with full term. Remember airway with C, spine control. B is breathing and ventilation. Then C stands for circulation and hemorrhage control. D stands for disability. D stands for disability, where you are performing the neurological assessment. E stands for exposure and environmental control, where you have to make sure the patient should not go into hypothermia. Now what is the secondary survey mnemonic? Once your patient is stable, then you will perform the secondary survey. Secondary survey you can remember it with the help of sample. So S is the sign and symptom or the chief complaint of the patient. A stands for any form of allergy patient have. M is medication, if the patient is taking any over the counter or medication or any specific prescribed medication which the patient is taking right now. Then P stands for past history, past medical history, past surgical history, past obstetrical history, all the past history we have to collect. L stands for the last meal patient had taken before this injury or this event occur. Then E is the event. What was the event? What was the patient doing? Whether the patient was driving when the patient had this experience of breathlessness or sweating, what was that event? So this is all you have to ask in under the secondary survey, right? So this is your primary and secondary survey. Now let us quickly revise the NG tube. IBQ question is must from NG tube. This is your image A, which is your nasogastric tube. Image B is your gravity feeding bag, right? So gravity feeding bag, it is basically we are using for continuous feeding purpose. Continuous feeding purpose, the drop factor of gravity feeding bag is 20 drops per ml, and this gravity feeding bag can be used for only 24 hours. After 24 hours you have to discard it. And where you will discard, let us also quickly revise this, because everything is integrated. It is in red because this is of plastic. Where you will discard NG tube, it is in red. All good plastic will go into red. Now what are the common sizes of NG tube that you need to remember? In case of adult, very unlikely that they will ask you infant and child. For adult, male and female, they can ask you. So for male it is 16 to 18 French, and for female it is 14 to 16 French. Do we need to remember the color? The answer is yes, we do have to remember the color. So what is the trick for remembering the color? Don't remember entire color, just start from the 12 French till the 18 French, right? Till the 18 French. So 12 is, the mnemonic is, first you have cloud. So in the sky we have cloud, which is white in color. So the cloud above us white in color, then below us, which is ground, and ground we have green color grass. Then under the ground we have orange color, which is orange color crust, and under orange color crust at last we have red color larva, right? In this way you can remember: white cloud, green grass, orange crust, red larva, right? It starts from 12 French, then 14 French, 16 French, and 18 French. What do we mean by French? French represent the outer diameter of a catheter. One more point that you can remember: the endotracheal tube and the tracheostomy tube is in the size of millimeter, which represent internal diameter, Okay, now method to check the appropriate length for NG tube, a 10-star question. Always remember, will measure the length of NG tube from the tip of the nose to the earlobe to the xiphoid process. So it is nose, then from nose to earlobe, then it is xiphoid process. Next, in this way you can remember: nose, tip of the nose, earlobe, xiphoid process. We are good to go. Now position. Which position you will use while inserting, while feeding, while removing? So always remember, while inserting it is high Fowler's position. High Fowler's position you will use while inserting the NG tube. Now there is one catch. I'm sure those who have attended the conceptual classes, they can remember the point that while you are inserting, here I'm in high Fowler position. So while you are inserting, once this NG tube is inserted inside the nostril, so once it is inside the nasopharynx, then you will ask your patient to flex the head, right? But once it is inside, once it is under the nostril, then you will tell your patient to flex. Why we are doing this? In order to make sure that the tube will not go into the trachea, right? Because we want the tube to go into esophagus. Before inserting, you can lubricate the tube by using KY jelly. Don't use xylocaine jelly, because in case accidentally if the tube will enter into the trachea, then it can block the airway, right? During intermittent and continuous feeding, for intermittent, it is an option, you can use Fowler position as well, right? And for continuous, we can place the patient in semi-Fowler position. Removal ke liye we can use high Fowler position. Now another, this is again 10-star question. The method to check the correct placement of NG tube. Once the NG tube is inserted, how you will check whether the tube is in place or not? So the best gold standard method, or most accurate method to confirm the placement of NG tube is X-ray. Most accurate method is X-ray. Now whenever you are performing any procedure, before doing any intervention, you have to check the placement of NG tube. Related to NG tube, for example, whenever you are giving feeding to the patient, you have to first check the placement. Which method you will use? Of course, in this case we will not use X-ray. In a day we have to give 4 time of feed to the patient. We will not check the placement of NG tube with the help of X-ray 4 time a day, because before giving, ma'am said that before giving feeding to the patient through NG tube, first you have to check the placement. So it is very unlikely that every time you are doing X-ray. No. So in such case, once you have checked the placement that yes, with the help of X-ray the tube is in place, after that what you can do, whenever you are using the NG tube, before using it you will use an aspiration method, right? So most common method is aspiration method, most accurate method is X-ray. The least common method is whoosh test, and surprisingly the whoosh test had also been asked in your NORCET. Whoosh test, let us quickly revise what we are doing in whoosh test, what all important supply we required. We need a stethoscope. So you need a stethoscope. You will use diaphragm of the stethoscope. You will place it at the epigastric region. You will use 20 ml syringe, and in the 20 ml syringe you will take air and you will you will inject the air through the NG tube. While administering, simultaneously you have to auscultate. If there is any whoosh sound is present, that means the tube is in stomach. But this is not a reliable method, right? This is not a reliable method, the bubble or the whoosh test. Chaliye, let us quickly revise the one liner related to NG tube. So which jelly we have already discussed. While inserting, always use K by jelly, not the water soluble, which is a water soluble jelly, which we should not use xylocaine jelly. If patient complain coughing and while inserting the NG tube, then pull back the NG tube. Do not completely take out the NG tube, just pull back the NG tube first and let the patient make a comfortable way, and then you can insert it. Confirmatory test we are done with, that is X-ray is the confirmatory test. Most common test is your aspiration method. Secure the tube at. Now recently in the previous NORCET 6.0 we have this question where you will secure the ET tube, and this is the reason why it is important for us, the securement of this tube. So NG tube should be secure on the nostril with the help of dynaplast. Right? NG tube is contraindicated in which case? If your patient is having head injury, facial trauma and basilar skull injury, right? So in such cases we should not perform a nasogastric tube insertion. Now related to the feeding you can what are the different method of administering the feeding? One is the continuous method, another most common was intermittent method. So in intermittent, either you can use the flow the infusion pump, or you can use the syringe, right? 50 ml syringe you can use to administer the feeding. Another important point is, if you are, let us start with the continuous feeding one, right? So you can have a flow while revising. If you are using continuous feeding method, will use gravity bag, that we have already revised, that gravity bag for 24-hour you will use. Now in continuous feeding means 24-hour patient you will administer the feed, but not continuously 24-hour. Once you will prepare the feed can be administered for 4 hours only. After 4 hours we have to give resting period, and then for 4 hours we have to start the feeding, and there is one universal period which is evening to the morning, that feed should not be administered to the patient. Now here what I need to tell you and we need to revise is, you have prepared the feed for 4 hours. Once the 4 hours is over, if there is a feed in a gravity bag, you have to discard that feed. You cannot use the same feed for the next 4 hours. No, for every time the feed should be freshly prepared. The same, how to discard? You can discard it and you have to wash the gravity bag, which is this one, with the water, the tap water, or you can use the the drinking water to wash this gravity bag. It is very important, make sure this is completely washed and should be used for 24 hours. After 24 hours you have to discard it. Okay ji, so this is how you have to done. Yes, now if once like I said that before administering the feed you have to aspirate the NG tube. Why we are doing this aspiration? To make sure to measure the gastric residual volume, because they usually, the people who are bedridden or those who are having this NG tube, they must have a slow digestion process. So just now you have administered the feed, and after 2 or 4 hours if you are again, as per the doctor order, you have to administer the feed. So before that you have have to check the gastric residual volume while aspirating. If the gastric residual volume is equal, more than or equal to 100 ml, then do not give feed, hold and inform to the doctor. This will be your priority nursing intervention, right? Now change the NG tube feeding bag and tubing. The NG tube gravity feeding bag, this we have already discussed, 24 hourly. Now for continuous feeding, once the feed is prepared, then we have to administer for 4 hourly at a time. After that, discard the feed, whatever left in the bag, then you have to wash the bag, and then you have to again freshly prepare the feed. Flush the NG tube. Mark this question, very important. Before and after feeding, what is the solution and what is the volume? So solution is, you can use normal drinking water to flush the NG tube, right? What will be the volume? 30 ml. 30 ml is the volume that we use before and after flushing the NG tube. Then place the patient in Fowler's position after feeding, once you are done with the feeding procedure. After that, there is a risk of regurgitation. So in order to prevent regurgitation, make sure your patient will remain in the same Fowler's position or in semi-Fowler position for minimum 30 minutes and maximum half an hour. So for 30 to 60 minutes, we will, after feeding, will place the patient in same position so that patient will not have this regurgitation problem. Do not administer cold feed, otherwise patient will have abdominal cramping. Right, related to the suctioning, yes, we can put the NG tube and we can connect it on the suctioning as well, especially in case of post-operative area after the abdominal surgery. You must have seen that patient NG tube is connected with the suction. What point we need to remember? Number one, whenever you are connecting the NG tube with the suction, what is the ideal suction? It should be intermittent, low intermittent suction. We should not connect the NG tube with continuous high intermittent suction, because otherwise what will happen, all the gastric content will be drained out, so which we don't want, right? What we have to do is, if you're connecting NG tube with the suction, always low intermittent suction, and continuous suction with the help of excessive vomiting and NG tube suctioning, your patient can be at risk for metabolic alkalosis. Always remember, patient can go into alkalosis because all the acid is drained out through the suction, right? So remember this point. Why you have to connect your NG tube with the suction? Because especially in post-operative region, patient are at risk for abdominal distension, right? Because of the absence of paralytical movement. So in case of paralytical movement or peristaltic movement or paralytical ileus, so if there is no peristaltic movement, patient will be having abdominal distension. That can further interfere with the breathing, because it will not let the diaphragm, which is dome shaped muscle, to completely, when we are exhaling, it will not let the diaphragm to go down, because here we are having distended abdomen, so patient will have breathing difficulty. This is the reason we have to put the patient on suctioning. Do not irrigate, right? If your patient is connected with the low intermittent suction after the abdominal surgery, do not irrigate the tube unless it is advised by the doctor, because while irrigating, we can put tension, we can put pressure on the suture line as well, right? So these are the important point. Now related to the medication, if you have to give medication through NG tube, which route you are following? The route of medication, it is right route. Through right route you are giving, because NG tube, if you have to give medication through NG tube, so you can only crush the medication, then only you can give. You cannot directly insert a tablet, right? So first you have to crush it, then you have to dissolve it, then you can administer it. What will be the solution that you can use? You can use 30 ml. You can use 30 ml water to dissolve the medication. Always remember, you have to administer the medication separately. Do not mix all the medication. Do not mix the medication with food. Medication should be given separately. Before medication, flush it with 30 ml. After medication, flush the tube with 30 ml. If you have to give multiple medication through NG tube, then in between the medication you have to flush the tube with 10 ml water, right? So this is all. And one more point which is very important, we do have a lot of form of drugs and medication. So there is one form which is sustained release, enteric coated. These are certain form of medication which cannot be crushed, right? Because they are meant to dissolve under the intestine. If you will crush these medication which are enteric coated or sustained release or control release, so you will dissolve their purpose. So do not crush enteric coated or sustained release medication. This is all about NG tube. Now, another very volatile, important topic, which is care of patient with CVP line. So, care of patient with CVP line, one of the very important IBQ. This is your PICC line, peripheral inserted central catheter. This is on the B. It is your CVP line, which is central pressure catheter. What is the normal CVP pressure? 3 to 8 millimeter of mercury is the normal CVP pressure. Most commonly, you will prefer triple lumen CVP line. What is this triple lumen? Right now, under CVP line, you can have various classification. We have tunneled, non-tunneled, PICC line, or implanted chemoport. So one is the CVP. Under CVP line classification, 4: tunneled, non-tunneled, PICC, and CVP line. PICC line, we have seen, this is the PICC line, which is inserted peripherally, right? The most common vein through which you can insert this PICC line is basilic, is more preferred than cephalic. Very good, right? Then if we talk about the tunneled and non-tunneled CVP line, then non-tunneled CVP line is used for short-term care, and tunneled one is used for long-term care, those who require a long-term care and require the need intervention through the CVP line. Now, which point we need to revise? If you'll remember that if your patient is having heparin-induced thrombocytopenia condition, for such cases, which tunneled CVP catheter is used? Grosjean. So remember, Grosjean was a tunneled CVP catheter, and this is more preferred because it has valve in it. This catheter has valve in it, so it does not require you have to clamp the catheter when they are not used, or whenever you are disconnecting any tubing from this lumen. You don't have to clamp it because it has valve present inside the catheter, right? This is the reason they, with the help of this, you don't require any heparinized flush, so you can prevent you can use this catheter in case if your patient is heparinized induced thrombocytopenia, right? This is the chemoport, the last classification of CVP line, which is the implantable chemoport you can use. Now let us quickly revise the crisp one liner related to the CVP. Preferred site for CVP insertion, yes, anyone can tell me? Quickly revise. It is, देखो पूरा याद रखना है, right? It is your right internal jugular vein. Most common site for insertion of CVP line, it is subclavian vein. Most common site with least risk of infection, subclavian vein. Most common site with high risk of infection and DVT, femoral. We all know this. You all are very intelligent. Most common site in emergency, because in emergency we have to quickly assess, quickly insert the line. We don't have that much time. So in emergency, femoral is more preferred. High risk of pneumothorax, so subclavian vein will have high risk of pneumothorax. Patient position while inserting the CVP line through the jugular or subclavian, it will be Trendelenburg position. Trendelenburg. Most common insertion of PICC line, which is basilic. Just now we have revised. Technique used to insert the CVP line, will always prefer the safest technique, which is Seldinger method, because we don't want to prick any wall of vein to unnecessarily, we don't want to create any hematoma. So we'll use a Seldinger method. We are inserting the needle through a guide catheter, through a guide wire. Solution used to clean the insertion site, it is 2% chlorhexidine gluconate solution, right? This is a Trendelenburg position, a very important IBQ. Now quickly we have one more question related to position. Suppose in case if you are inserting the CVP line, and while inserting your patient suddenly developed respiratory distress, difficulty in breathing, and sharp shooting pain on the insertion site. So basically that means your patient has experiencing pneumothorax and air embolism entry. So what position you will give in this case? You will place your patient on left. It is Durant position, but I'm sure they will not, because examiner is very smart. Do not underestimate your examiner, right? So examiner is smart. They will not give you the option as Durant position. What they will do, they will ask you option A right, option B left, Trendelenburg or Trendelenburg. So always remember, we'll place the patient on the left lateral, head down. Then in CVP, another very important is the most common CVP line that we are using in clinical setting is triple lumen, because CVP insertion is a very tedious task and we don't want to do again and again unnecessarily, right? So this is the reason, use it with multiple lumen, so that our various purpose get solved. So triple lumen CVP most common, which we have distal lumen, proximal and medial lumen. Do we need to remember the color? Yes, we need to remember the color. So we have one is the distal lumen, which is brown in color, right, which is brown in color. One is brown color, then we have blue color, another one is white color, BBW. So we have BBC news channel, you can remember it as BBW, right? So B is brown, B is blue, and another one is white. Brown is the most important lumen, it is a distal lumen. Cut. Start. So usually we'll give priority to the lumen which is very important, right? So CVP line is very important because we can monitor the CVP pressure, and the you can monitor the CVP pressure to that lumen which is very important. An important one is the brown, which is distal lumen. So distal lumen is always very important, right? Distal lumen is used to monitor the CVP pressure. Blue lumen is used to administer the total parenteral nutrition, which is your median lumen. Blue is median, brown is distal, and last one bichara, it is your proximal lumen. So proximal lumen is the one which you can use for all form of intervention. You have to administer medication, you have to take the blood sample, you have to administer any IV fluid, you can use with the white proximal lumen, right? Now the dressing part. So if your patient is having a transparent dressing like this, then how frequently you have to change? It is 5 to 7 days, or when it gets soiled, right? If your patient is having such type of gauze dressing, then every 2 days you have to change, because if gauze is present, then you cannot visualize the site whether any sign of infection is happening or not, right? This is what you need to remember. Then which solution you will use? If you are cleaning this site, then 2% chlorhexidine gluconate solution I will use. If I am using this, I am cleaning this side, 2% chlorhexidine gluconate. Then these are the hub part. Hub I will clean with the help of alcohol swab, 70% alcohol swab. Whenever you are using a CVP line, before and after using, you have to clean the hub. How frequently I have to clean the hub? Before and after using. Before and after using. Great. Okay, so transparent dressing we have revised that every 5 to 7 days. Gauze dressing every 7 days. After removing the, now your doctor has given an order to remove, doctor will remove the CVP line. The doctor has removed the CVP line. After removing there, the insertion site will be having an opening. So that insertion site needs to be covered with what we can cover, and for how long we have to keep that dressing. So it is transparent. Transparent occlusive dressing should be placed over the point after the removal of CV, central venous access device, and it should be kept for 72 hours. After 72 hours, we can remove it, right? Then CVP line flushing method, we have to flush the CVP line regularly, otherwise it will get blocked. The clot formation can occur, right? Normal saline, the standard practice says that normal saline we have to use. We don't have to go with the heparinized flushing solution unless it is not advised by the doctor, right? How frequently one should flush? If the lumen, if any of the lumen is not in use, then you can make sure flush the line once in 24 hours, right? Then method, which method you will use for flushing? It is push and pause method, or you can say pulsatile method, because in one go you don't have to flush it. You have to create a pressure so that if any debris is there, it will get flushed out, right? So push, pause, or pulsatile method, or turbulence method you have to use. Which solution you have to use? Like I said, that normal saline isotonic 0.9% is preferred. Which ml syringe you will use? So remember, 10 ml syringe is more preferred, but do not use syringe which is smaller than 3 ml, because the smaller the syringe, and it will generate more pressure, which can damage and it can damage the catheter lining. So do not use syringe less than 3 ml. Ideal syringe is 10 ml. Purpose of flushing: to maintain the patency of the line. IBQ, another very important IBQ, this is your CVP manometer. With the help of this, you can monitor the CVP pressure. So the point which although here in the revision part I be not going into the detailed procedure of CVP, how to monitor, but what are the pointer is where you have to make sure the zero and leveling at the point of phlebostatic axis. Where is your phlebostatic axis? Fourth intercostal space, mid axillary line, right? So fourth intercostal space is the point which create a phlebostatic axis where your right atrium is present. Chaliye, so if you are measuring a CVP pressure with the help of transducer, and if you will place the transducer at too high, it will give falsely, what reading will it give? So if you will place the transducer too high, it will give low reading. Remember, it will give false and low reading. If the transducer is too low, it will give false and high reading. Now another important table which you need to revise is in which condition we can have increased CVP pressure and what are the condition we can have decreased CVP pressure. So shock and hypovolemia, very easy to remember. When we have shock and hypovolemia, we have decreased CVP pressure. In case of fluid volume overload, right heart failure, these are very important. Cardiac tamponade, tension, pneumothorax, pleural effusion, all those immediate measure, the immediate where condition where we require immediate intervention. Though we require immediate intervention in hypovolemia and shock as well, but you can remember in this way that in case of cardiac tamponade, pleural effusion, tension, pneumothorax, right side heart failure and fluid volume overload, we require the CVP pressure will get increase. The complication of your CVP line, the most common preventable complication is infection, which is 𝒅𝒏𝒅. The most common complication is infection, right? But this is a late sign. This is basically a late complication. Immediate complication can be arrhythmia if you insert the catheter directly into the right atrium, because ideally the catheter should be present just above the right atrium. So we can have arrhythmia, we can have hematoma, we can have pneumothorax with the help of air entry, right? Air entry and accidental arterial puncture can also occur. Early complication is pneumothorax and catheter blockage can occur if you will not flush the catheter properly. Next, another volatile topic is your chest tube drainage. Under the chest tube drainage, what are the important one-liner point is always this is how your chest tube drainage look like, right? Under this chest tube drainage, always make sure this is your collection chamber, this is water seal chamber. Under water seal chamber we have air leak monitor, and this is your dry suction chamber which has a suction bellow, right? So one by one, once your suction chamber is completely full, do not do not empty this collection chamber. We have to replace it, point number one. Second is the water seal chamber. In the water seal chamber, we have to check for the bubbling, right? This air leak monitor, we have to check for the bubbling, and if the bubbling stop, if the bubbling stop, there is no bubbling, then what could be the reason? Two reasons. Either the lungs are re-expanded, the solution, the problem has resolved, or there is kink or obstruction. If there is too much bubbling, continuous bubbling, then there is air leak. The reason it could be because of air leak. What is the normal bubbling? It is gentle intermittent bubbling should be there in the water seal chamber. It says that the chest tube is functioning perfectly, right? The suction, we have two form of suction under this water seal chamber. One is the dry suction chamber, another one is the wet suction chamber. So if you have a chest tube under water seal drainage which has dry suction regulator, the suction should be kept at minus 20 centimeter of H2, right? In case of dry suction, there will be no bubbling in the dry suction chamber. If you are using a wet suction chamber, then under wet suction chamber, you will have continuous bubbling. So many times students get confused when they say that patient is having continuous bubbling in a suction chamber. That is normal. But if they ask you that continuous bubbling, examiner don't know that this time the student, especially the student of Nursing Next Live, they are way more smarter, right? So examiner, you have to be very smart. You have to show them that you are you know everything. So in case if you are having your wet suction chamber in the underwater seal drainage, under wet suction there will be continuous bubbling, right? So if question says continuous bubbling in suction chamber, that means it is normal. If question says continuous bubbling in water seal chamber, this is not normal, it indicate air leak. ठीक है जी. Then triangle of safety, when the surgeon is inserting this chest tube, what will be the site and what is the triangle of safety? So usually the chest tube is inserted under this triangle of safety. So with this fifth intercostal space, the upper border of the fifth intercostal space, right? Upper border, not the lower one. So we have lateral edge, one side, posterior side we have lateral edge of latissimus dorsi. Anteriorly we have lateral edge of pectoralis major, and we have base of axilla, and below we have fifth intercostal space. Why we are inserting this? Because there are no major vessels and network though to get damaged when you are inserting the chest tube catheter. What is the site? You can say here it is fifth intercostal space, mid axillary line in case of adult. In case of child, the site will be second intercostal space, mid clavicular line. So this you need to revise, and this you can, I have posted the Insta flashcard on my Instagram channel. My Instagram channel is Nursing Ka Funda with Sabina. So this is my Instagram channel, Nursing Ka Funda with Sabina, where I will be taking the live classes, and I have lot of learning flashcard with which you can make the notes as well. So this is how your chest tube catheter look like. It also has this radio opaque line which is visible in the X-ray. Okay ji, and let us quickly revise. So yes, we are done with continuous bubbling in the water seal chamber, indicate air leak. Continuous bubbling in the suction chamber is normal. Absent bubbling, either lungs are re-expanded, the problem has resolved, and it is indicating any kink or obstruction. In case if the tube accidentally the chest tube catheter is removed from the insertion site, what do? What we will do, if the chest tube is removed or dislodged from the insertion site, we will with the help of sterile glove, we will cover the wound with the petroleum gauze dressing and we will fix the dressing with only 3 side adhesive. One side should remain open, so that in case of tension pneumothorax, let the air get escape from the lungs. Do not, if the air will get accumulated, the tension will the patient will have further mediastinal shift. So always remember, 3 side dressing occlusive, you have to fix, secure it, and one side should be open. In case if the chest tube catheter is disconnected with the underwater seal drainage bubble tube, and the bubble tube is now lying on the floor, so that will become, that is become contaminated. You cannot use the same and connect it again with the chest tube catheter. And if you will go and bring the fresh underwater seal drainage bag, it will take time. So what you will do, by the time we want to make sure that not all environmental air will go through the chest tube catheter into the patient lung, what you will do, you will just place the tip of this chest catheter into a normal saline bottle. That's it, right? Tubing suction pressure we have already discussed. It should be minus 20 centimeter of H2O, right? So this is how the chest tube look like. And yes, this is your another chest tube underwater seal drainage with the wet suction chamber. So here we are having wet suction chamber, which will be having sterile water in it, and here you can see continuous bubbling, right? So before using this chest tube catheter drainage system, before connecting this underwater seal drainage system with the patient chest tube catheter, always make sure prime this drainage bag. How you will prime it? There is a air leak monitor. You have to fill 20 ml of sterile water, which means that the tip should be 2 centimeter deep. It should be 2 centimeter, right? Itna आपको याद रखना है. This you need to remember. Now another very important IBQ, this is flutter valve or Heimlich valve. If you want to transfer your patient from one place to another place, and this underwater seal drainage, it should be kept below the chest level always, and it will be very difficult for patient to transfer. Many time it happens, so the tubing can get disconnected. So instead of transferring a patient with this drainage bag, what we can do, you can connect the chest tube catheter with this Heimlich valve. So this is a one-way valve. The air basically can enter from the chest tube catheter into this, and it will not go back, which is our entire purpose. Chaliye, another very important IBQ. So here we have two important tube. The image A, here you can see SBT, Sings taken Blakemore tube. Image number B, which is Minnesota tube. This one is more preferred because why? What is the basic difference? It has only 3 lumen. 1, 2, 3. It has 4 lumen. What are these 4 lumen will do? So one will use to inflate the gastric balloon, one inflate esophageal balloon, one will do the suctioning of gastric, one will do the esophageal suctioning, right? So this is the reason why Minnesota tube is more preferred. Let us quickly revise. If you're now where you are inserting this Minnesota or SB tube, in case if the patient is having esophageal varices, right? So in that case you will use. Do not inflate the esophageal balloon. Always first we should go with the gastric balloon. How what will be the solution? We are using air. With the help of air you will inflate the gastric balloon. What will be the volume? In case of Minnesota it is 4 450 to 500 ml. So first what you have to do, first you have to use 50 ml syringe and you have to take 50 ml air, then inflate the gastric balloon with 50 ml air, then you have to done an x-ray that everything is fine. Then once you have seen that the yes tube is inflated in the stomach, then you have to inflate it fully, which is the maximum volume of air that you can use to inflate the Minnesota is 450 to 500, right? Once after inflating the gastric balloon, then what you have to do, you have to apply the traction. You have to apply the traction with the help of bandage. You can hang 1500 to 1 kg weight traction you can apply and hang it on the IV stand. If in case the bleeding will not stop even after inflating a gastric balloon, then you can inflate the esophageal balloon, but do not let the esophageal balloon inflated for more than for more than 6 hours. Otherwise patient can have esophageal necrosis because it can create pressure to the esophageal lining. Now what will be, how you will inflate the esophageal balloon? So for inflating the esophageal balloon, we don't want to use a syringe. Simply you can use a cuff manometer. I'm sure you can remember our endotracheal tube class. So we have a cuff manometer. You can simply use a cuff manometer to inflate the esophageal balloon, and up to what pressure you can inflate, it should be equal or less than 45 millimeter of mercury. That's it, our work is done. Another point, whenever you are having such type of patient, make sure a pair of scissors should be kept at the patient bedside, because if any emergency occur, you can cut the tube from the top and take out, because for 500 cc of air you have you have injected to inflate the gastric balloon. When emergency will come to withdraw and deflate the balloon 500 cc 500 ml, it will take a long time. So just simply cut the tube from the above and take it out, the air will come out. Now revise color coding of gas cylinder. Now you have to tell me quickly, this is your oxygen which has white shoulder, black body. This is nitrous oxide, completely blue. Then we have black and white and gray, this is your medical air. Then we have completely black, this is nitrogen. Completely gray, this is carbon dioxide. Completely brown is helium. This is something interesting, which is blue body, and in the shoulder we have quadrant. We have which one quadrant is white. So this is Entonox, which has 50% oxygen and 50% nitrous oxide, right? So this you need to remember. So now let us quickly revise the oxygen therapy. The most common question then can be asked, always remember the low flow and high flow device. Low flow and high flow device is very important. Under low flow we have all the devices: face mask, nasal prong, the nasal cannula, and we have your non-rebreather mask, right? Partial rebreather mask is absolute no where we are using. So these are low flow device. Under low flow, the non-rebreather mask is delivering the high concentration of oxygen. So whenever the question can ask that which mask deliver high concentration of oxygen, the answer will be non-rebreather mask. Then we have high flow oxygen device. Under high flow we have our favorite, which is Venturi mask. Venturi mask work on the principle of Bernoulli principle, right? Under Venturi mask, it is a high flow device, but it does not provide high concentration of oxygen. High flow oxygen device, Venturi mask. Low flow oxygen device, non-rebreather mask. Now let us see images. This is your simple face mask, this is your nasal prong, and here this one we have Venturi mask, this one is non-rebreather mask, right? We have to make sure this reservoir bag should be half filled. Always it should be half filled whenever you are using this, right? Okay, in Venturi mask we have certain color coding of orifice or valve that should be revised. Very important 10-star topic. What is the flow rate and what is the percentage of oxygen FiO2 we can deliver, which all of these color coding. How you can remember? The best mnemonic is boy. So in boy, after B we have W, which is silent. So boy, red flag or green flag. Nowadays on the Instagram it is very common, the video are commonly the viral video are that we have a boy which is whether he is in red category, red flag, or a green flag. So you can remember boy, red flag or green flag. So B stands for, and that is to be remember, you can revise in a sequence, so that will be very helpful. B stands for blue color. So blue color basically 2 liter per minute and it can deliver 24%. Then W is white in color. White basically can deliver, white means 4 liter per minute and it can deliver 28%. Then O is orange, right? Orange will be 6 liter per minute and 31%. Then Y means yellow, yellow is 8, 35. Then we have R means red, 40 and 40, and it can deliver 10 liter per minute. Last is the green flag, G, which is 60 and 10 liter per minute. So here with the help of Venturi mask we can deliver 60% concentration of oxygen. But with the help of non-rebreather mask, you can deliver, with the help of non-rebreather mask you can deliver more than 90%. So always remember, with the help of non-rebreather mask, we can deliver more than 90% of oxygen. Mask with the reservoir bag, it is obsolete, which is your partial rebreather mask, right? So this you need to remember, and this is highly important. Highly important. Now let us proceed with another very important topic. With the image, I'm sure you all can identify. This is your endotracheal tube. The size of the endotracheal tube is in millimeter, which represent internal diameter. This is your adapter, which is standard size 15 millimeter. It is detachable, proximal and distal end, right? We have Murphy's eyes just above the bevel. This is your bevel, which is on the distal tip. Just above the bevel you have Murphy's eye. This is your cuff. The volume of air that we use to inflate the cuff is 2 ml of air. That's it. 2 ml of air we'll use to inflate the cuff. The cuff pressure should be 20 to 30 centimeter of H2O, 18 to 25 millimeter of mercury, and we'll use cuff manometer to monitor the pressure, right? This is the one-way valve through which you will inflate the cuff. This is an entire radio opaque line. And now here with this endotracheal tube, the formula, how you will get to know, how you will select the appropriate size of ET tube. So for cuffed endotracheal tube, age divided by 4 plus 3.5, uncuffed age by 4 plus 4. How you will remember it? Because cuffed one you are using it for the adult. Usually cuffed one, the cuffed endotracheal tube you are using for adult. So in adult they'll be able to do the decimal calculation. So it is age divided by 4 plus 3.5, the decimal. Uncuffed you are using for infant, and they have to, they can only do the simple math, so without decimal. So plus 4. This is how you can remember. What is the position while intubating and extubation? The answer is sniffing position. Remember the sniffing position. What position you will give while suctioning? So head of the bed at 15 to 30 degree angle. You have to place head of the bed at 15 to 30 degree angle. Now endotracheal tube insertion is called intubation. Removal is called TT removal. Here you are not asking ET tube. TT removal is the only special case, which is called decannulation. Decannulation. Right? Bevel of the endotracheal tube is on left side. ET tube is inserted from which side? So usually if the bevel is on left side, we are inserting in the right side. ET tube size in millimeter, which represent internal diameter of the catheter. Size estimation formula हमने पढ़ लिया है, which is age divided by 4 plus 3.5 in adult, where we are using cuffed one, and age divided by 4 plus 4 in uncuffed one. Then the ET cuff pressure measuring side हमने कर लिया. Standard size of proximal adapter 15 millimeter. The best method to confirm the placement, always remember, it should be capnography, which is a quick method that can be used. So here the best method is capnography. Most accurate will always remain X-ray. Best position while intubating, sniffing position, the colorimeter. So we do have a different method, right? So first is, this is your sniffing position, right? This is your cuff manometer. Another remain, lots of images are there. Cuff manometer to measure the cuff pressure. Sniffing position, right? And then this is ho gaya. Then colorimeter. Let me show you. Okay, yes. So the best method to confirm the placement of ET tube is capnography. In capnography, what we will assess? End-tidal carbon dioxide. End-tidal carbon dioxide. We do have one more method, which is colorimeter. What is this colorimeter? It is not a reliable method, least reliable method, where we have a pH paper in our device. So when the patient exhale the carbon dioxide, when the carbon dioxide will pass through this device, so this purple color pH paper will turn into yellow color, right? On exhalation, when the patient exhale, carbon dioxide will release. So this purple color will turn into yellow. This you need to remember, but this is a least reliable method. The color will change from P to yellow, purple to yellow, right? Purple to yellow. So yes, and now what is the ideal depth of endotracheal tube once it is inserted? It should be, always remember, 5 to 2 centimeter above the vocal cord. 5 to 2 centimeter above the carina, right? 2 centimeter below the vocal cord, 5 to 2 centimeter above the carina, which is a thin layer where the trachea is bifurcating. Then the method to confirm the placement of NG tube, capnography is the best method. Capnography, where you are measuring the end tidal carbon dioxide. So next is suctioning. Under suctioning, which is very important, before suctioning always pre-oxygenate your patient for 30 seconds, which is 6 breath 5 second. So 1 breath, 6 breath dena every 5 second interval pe we have to make sure that patient should be fully pre-oxygenated before suctioning. Then you should never apply pressure while inserting the catheter. Always remember, duration of suctioning is always 10 to 15 seconds, but if the examiner asks that if the examiner will give you option in such a way that there is 10 second also, 15 second also, what you have to select? 10 second. Suctioning will always be 10 seconds. So 10 second is your time. We have open suctioning method, which is a sterile procedure. We have a closed suctioning method, which is a clean procedure, right? Rattling and rhonchi, these are the auscultation sound, breath sound that indicates secretion is present. You have to do the suctioning. And in case while suctioning, how you will do suctioning? You have to insert the catheter. Do not apply pressure while inserting. Once you have met the resistance, now the catheter is not going beyond, then you have to pull the suction catheter 1 to 2 centimeter up. If you will apply the suction pressure from the point of resistance, then patient can go into bradycardia, right? So this is your closed suction catheter. This is your longer tonsil tip in order to provide the oral suction. What is the sequence of providing the suctioning? So number one is you have to provide, so first you have to do the endotracheal tube suctioning. Second, you have to do the oropharyngeal suctioning, that means orotracheal suctioning, then oropharyngeal suctioning, and last you have to do nasopharyngeal suctioning. So first M, then N. You can remember, first you have to do the AT tube suctioning, then you have to do oral suctioning, oral cavity, then nasal cavity suctioning, right? Then this is your suction machine. This is your portable suction machine. This is your wall mounted suction machine. What we need to remember is the suction pressure, portable suction pressure and wall mounted suction pressure, right? Then next is your suction, the most controversial question. What is the size of suction catheter that one should select? So remember, there is one formula, only one formula, forget about other. Only one formula you have to remember. What is that formula? In order to rule out the size of suction catheter, you need size of endotracheal tube. So whatever size endotracheal tube you have to divide it by 2. Right, you have to divide whatever you will get. Let's solve this. So for better understanding, so let's take an example. You have a patient and the patient endotracheal tube is 6 millimeter. So in order to find out the suction catheter, and suction catheter will be in French, right? Suction catheter. So suction catheter is in French. And suction catheter ke liye what we have to do? We have to take the size of endotracheal tube divided by 2. So that will give us 3 millimeter suction catheter. So will it be the correct size of suction catheter? The answer is no, because here the unit is millimeter and we have to find out the suction catheter size in French. Now we have to convert it, right? So 1 millimeter is equal to 3 French. 1 millimeter is equal to 3 French. Millimeter is a bigger size, French is a smaller size. Whenever here we have to 3 millimeter, we have to convert it into French, right? So we know whenever we are converting any higher unit to the lower unit, the task is easy. We have to multiply with the difference, and the difference is of 3, right? So what we can do, the suction catheter size in French, 3 millimeter multiply by 3, that is your French, will make 1 millimeter. So millimeter to millimeter cut, and the 3 to 3 is 9 French. So will it be a correct size? No. Wait, what we have to do, the final answer that you will get, you have to select one size up. That's it. So you have 9, you will select one size up, which means 10 French. So all usually the suction catheter are in even number, so 10 French will be the correct answer. Right, now let us quickly revise the IV cannula, another very important point. And for IBQ, this is your orange, which is 14 gauge, then we have 16 which is gray, then 17 white newly added, then 18 gauge green one, then आपका 20 gauge pink color, then 22 blue color, 24 yellow color, then we have 26 violet color. Most commonly question was asked on the green color, which cannula is used for blood transfusion, for OT, for any diagnostic investigation where you need to put the insert the contrast medium intravenously, right? All these three can be used for trauma patient, where you need to give massive blood transfusion or massive fluid resuscitation. This we can use in case of adult for routine purposes, for routine intervention. This you can use in case of older adult or child where the vein is not that much prominent. So remember, this yellow one and the violet one is used for your infant, right, in case of infant. Now what is the flow rate? Again, let me tell you, I know you must be having this question that we have different value for flow rate. So this is because the flow rate depend upon the manufacturer, and we can have a we can see the variation in the flow rate. But for you, I got a cover. The only thing that you need to remember is very important, which is 18 gauge. If they can ask you, they can ask you this 18 gauge flow rate. So flow rate is basically the volume of fluid that you can administer through that particular IV cannula in 1 minute. So 90 ml around something you can write down, somewhere around 90 ml is the flow rate. This is the ml per minute you can administer through green one. This is very important. And up to 300 to 70 you can use it for 14, up to 180 16, then pink it's somewhere around 60, blue is 36, then we have 20, and last is 30. Now let us quickly revise the complication here. Image number A, you can see this is infiltration. Image B is phlebitis, and image C is extravasation. Phlebitis is the most common complication of IV line. Phlebitis is most common, right? How you can remember? By the sign and symptom. Here you can see the skin is pale, blanch, swelling, induration, and burning sensation. Here you can see, and this is cool to touch. Here you can see redness, erythema, pain will be there, tenderness will be there, warm to touch, right? Here you can see the condition is more worsen. Hematoma, necrosis can develop. So this is your extravasation, which can be occur due to vesicant drug leakage into the surrounding tissue. Now let us start another very important topic, which is urinary catheter care. So under urinary catheter care, the first thing that we should remember is the size of catheter. These are very important, can be asked, and in the previous year NORCET examination the size have been asked, right? French means we have already discussed external diameter. Do we need to remember the color? The same color. It is the same color that we have the NG tube. Remember, from 12 to 18 French, 12 wala is cloud, which is white, 14 French grass, ground, then 14, 16 is orange, the crust, 18 is red, the larva. This is the same, which is your 12 white, green, orange, and red. This is how you have to remember. Right, we have this balloon. The solution that we use to inflate the balloon is sterile water. Normal saline is in case of old guideline, we have to use normal saline, but nowadays we are not using normal saline because it can get crystalloid. Okay ji, so this is double lumen. This is your Robinson catheter, which is a plain catheter. It is not a self-retaining catheter. Here you can see all these catheter are self-retaining. So double lumen Foley's catheter, it is indwelling Foley's catheter. It is triple lumen, commonly used for TU, RP cases, and this is your Mellicott catheter. Many time it happened that Mellicott catheter cannot be in orange color, because we used to have a habit of seeing the Mellicott catheter in orange. When we see there is an orange catheter, will say this is Mellicott. No, you have to think ahead, one step ahead from examiner. So this is your Mellicott catheter, commonly a self-retaining catheter. This one here is a silicone catheter. Always remember, these Foley's catheter we can use for up to 28 days maximum. The range is 14 to 28 days. Silicone catheter is used for long-term patient for 90 days, 12 week or 3 month. right? Do not insert needle into the silicone catheter. If you have to take the sample, then we have a sampling collection port available on the euro bag, right? This is available on the euro bag, the sampling collection port. You have to withdraw the sample. Before withdrawing the sample, you have to apply the clamp for minimum 30 minutes, right? For minimum 30 minutes you can clamp the tubing, so that you can have enough sample for the you can have enough urine for the sample. Now let's talk about the one liner for urinary catheterization. So catheterization is a sterile procedure, but catheter care is a clean procedure, right? So what position you will give to the patient while inserting the catheter? It should be not it should not be lithotomy. It is dorsal recommend, and for male it is supine. How frequently you have to provide catheter care? In every shift you have to provide catheter care. Why we are providing catheter care? To prevent the COTY. Indwelling catheter, this we have already done, and this we have already discussed. Now next, let us start with the pressure ulcer. So pressure ulcer is also known as decubitus ulcer or bed sores. The most common site is sacral, and usually they can ask you in which position the patient will have more point pressure ulcer. So remember, by the position you can refer my Instagram also. I have added the Insta flashcard, right? And other than that, the most common factor that can lead to the development of pressure ulcer is poor sensory perception and immobility. If your patient is bedridden, so the patient is more prone for the development of pressure ulcer. Early sign for pressure ulcer is discoloration of the skin. What is the common scale? The Braden scale and the Norton scale. Now let's talk about the stages. There are 4 stages, and among the 4 stages, apart from 4 stages, 2 additional stages. One is the stage 1. Stage 1, always remember, the trick is the skin is completely intact. There is no tear in the skin. The skin will be reddened, erythema will be there, and non-blanchable skin. That means pressure, it is stage 1 pressure ulcer, right? So it is intact and non-blanchable erythema. If in case, do we need to apply any dressing? The answer is no. But if in case they ask you that you have to put a dressing, then it should be the transparent dressing. Now stage 2 can be of 2 characteristic feature. Number 1, stage 2, we have a skin is not intact. There is a tear in the skin. There is a loss of epidermis and dermis, which here you can see, or you can have a blister which is filled with a serous fluid. So in case of blister, there is no need to apply any dressing. But if you have this type of stage 2 pressure ulcer where there is a skin thickness, superficial skin thickness loss, then you can again you can use hydrocolloidal dressing. Then stage 3, the pressure ulcer has extended and now has involved the subcutaneous tissue. You can use hydrocolloidal dressing, which is best for pressure ulcer. Stage 4, when the pressure ulcer has reached up to bone, tendon, ligament, the major stage, right? So this is your stage 4 pressure ulcer. Now another 2 additional stages, deep tissue and unstageable. Unstageable, the name itself is given because we have no idea whether it is stage 2, stage 3, stage 4, because the wound bed is completely covered with this yellow and black stuff. So this yellow is slough and this black is scar, which is dead tissue. So the scar is dead tissue, slough is the exudate part which is covering the entire wound bed. So in this case you have to first perform debridement to identify that which stage is pressure ulcer is, and then you can move for further treatment, right? Then we have a deep tissue injury. This is basically another stage where you have intact skin or a blister formation, right? Either the intact skin or a blister formation. Intact skin which have maroon and brownish discharge because of the shear and friction, the skin tissue got damaged. Or if it is a blister, then blister will filled with serosanguinous fluid. Now, what are the common intervention that should be applied in order to prevent the pressure ulcer? First and foremost, position change. Every 2 hourly you have to change the position of the patient. If your patient is completely bedridden, then use water and air mattress. Use a sequential calf DVT pump in order to maximize the circulation and in order to prevent the deep vein thrombosis as well. Then you have to focus on the nutrition part and elimination part of the patient. The bedsheet should be wrinkle free. Another very volatile topic is your CPR, which is cardiopulmonary resuscitation. Remember the 3 cardinal signs of cardiac arrest. The patient is not responsive, having no respiration, no pulse. Start the CPR. Now let us quickly revise the one-liner. So what is the pulse site for adult? Always remember carotid. For child, carotid is given more preference than femoral, which means if you have carotid and femoral both are there in the option, will select carotid. For infant, it is brachial. right? Duration for assessing the pulse, it should be 5 second minimum, but not more than 10 second. Location of chest compression, lower one third of sternum. What is the depth of chest compression? In case of adult, it should be 2 inches 5 centimeter, child 2 inches 5 centimeter, adult 1.5 inches 4 centimeter. Maximum depth of chest compression beyond which we should not go in adult, it should be 6 centimeter 2.4 inches. What is the ratio of chest rate? The rate should be 100 to 120 compression per minute. Ratio of, whenever you are attempting such type of question where they ask ratio of chest compression ventilation, so special focus should be number of rescuer. If you have say single rescuer, the ratio will remains the same, 20 to 2 for all, adult, child, infant. In case if you have multiple rescuer, for adult it is 3:2, for child and infant it is 15:2. Minimum interruption should be of 10 second, not more than 10 second. If you will interrupt the CPR, then it will not consider as effective CPR. ROSC is return of spontaneous circulation. We have to assess the pulse. How frequently you have to assess the pulse? Every 2 minutes or every 5 cycle of CPR, you have to assess whether the pulse has achieved or not, right? So this we have done, and this is also we have covered. This is also we had covered. Breathing, we can give ventilation through pocket mask or either with bag valve mask. While you are giving with bag valve mask with BVM, always remember this C&E clamp. So this C&E clamp is used to make sure to provide a complete seal and to lift to straight, to make the airway straight, so that whatever air you are providing, it will directly go into the air. Always remember, when you are providing the breathing and if the chest fall and rise does not occur, you have to remove the airway and you have to again position the airway. Okay ji, and what is the rate of breathing in case of advance, or in case if you are manually giving the rescue breathing, then advanced airway means ET tube is in place. In all the cases, the airway will remains the same for adult and for child. So remember this and revise, this is very important. Now identify the image. This is jaw thrust. If your patient is having road traffic accident or spinal cord injury case, we will open the airway with jaw thrust. In this case, head tilt chin lift method, we can also use this method to open the airway, but not in case of RTA cases. This is the automated external defibrillator AED machine that you can use in in the CPR process, and any layman person can use, because this is automatic machine. Where will be the pad placement? In case of pediatric, we have anterior lateral. In case of adult, it is in case of lateral adult, it is anterior lateral. In case of pediatric, anterior posterior. Right? What are the shockable rhythm? Ventricular fibrillation, ventricular tachycardia are the shockable rhythm. Non-shockable rhythm is your asystole and pulseless electrical activity. Now this you need to remember that what we should do in shockable and non-shockable rhythm. So for shockable, as soon as possible you have to deliver the shock. CPR you will start, and then if you have a defibrillator or AED machine, deliver the shock, right? So CPR, shock, medication, this will be the management for shockable rhythm. Non-shockable rhythm, CPR and medication, this is the only management. Then 5H and T. Now you have done everything, but still the patient is not reviving, still the pulse is not coming, then we have to think for something other reason, right? Some other causes of cardiac arrest under this 5H and 5T. 5H में hydrogen ion, which is acidosis, hypoxia. Then you have hypovolemia, hypothermia, hypokalemia or hyperkalemia. 5T, under 5T, toxin, infection, tamponade, coronary thrombosis, pulmonary thrombosis, and tension pneumothorax. So these are 5 HNT that we need to remember. Then we have the chain of survival, element of chain of survival. Do remember and pay special attention. Outside hospital cardiac arrest and inside hospital cardiac arrest, the link, right? So outside hospital cardiac arrest, you have to immediately activate the emergency medical service. Then you have to start with the chest compression. Then AED machine comes, then give shock. Then you have to shift shift the patient to the advanced care. Then if the patient survive, then recovery. If the patient we have to first transfer the patient to hospital, then advanced care, and then we have to, if the patient survive, then we have to shift the patient for recovery. In hospital, first will not activate the service. First we have to recognize that this is a cardiac arrest, right? Because we all are professional. Once we'll recognize that this is a cardiac arrest, then we will activate code blue. Then cardiac arrest, then आपका defibrillation, shock delivery, and if the shock patient revive, then we have to go for post cardiac care once the patient revive, and last is your recovery. Then next come your Heimlich maneuver that we have to perform in case of adult, in case of choking, right? In case of choking, which volume of air you will use? You will use residual volume if you will deliver Heimlich maneuver, also known as abdominal thrust. That can only be performed if your patient is conscious. If your patient become unconscious, then you have to start the CPR. In case of infant choking case, then you have to use 5 back slap followed by 5 chest thrust. This is how you have to do if the infant is conscious. The moment infant become unconscious, use CPR, right? So this is your physical examination step. Remember, the physical examination step is inspection, palpation, percussion, auscultation. But in case of abdominal examination, the sequence become inspection, auscultation, percussion, palpation, because we have to do the auscultation first, right? Then the rule of 9, this is the rule of 9. Remember, many time question I've asked, so keep on revising the image. Look at this image very carefully for adult and for infant, because here we need to identify the total body surface area involved in the burn. We will use this rule of 9 in Parkland formula only for second and third degree, not for first degree, right? What is the Parkland formula that we are using? As per taking the experience from the ESIC, still the examiner, they are using this old formula: 4 ml ringer lactate total body surface area multiplied by body weight in kg. But remember, this is the old one. The new update says 2 ml plus total body surface area multiply by weight in kg. So which one we have to apply? So I would recommend that you can solve the question first by applying the old one. It will not waste your time. Now this is a table which you need to remember. What do we need to remember everything? No, just remember the adult point, adult scenario. What is the expected urinary output in case of burn of adult should be there, and what is the formula that we have to use. That's it. We are good to go. Right. Now next is the BMI formula. The BMI, the body mass index formula, you have to remember, because this is commonly asked in recent government examination. So remember, this is weight in kg divided by height in meter whole square. But if examiner will give you weight and height value in the pound or inches, then do not convert, because it will become very lengthy. You can use this formula if you have value of weight and height in pound or inches. This is another very 10-star topic. What is the range of BMI? So normal range, underweight, overweight. So underweight, if it is less than 18.5. What is normal? 18.5 to 24.5. So this is how you have to remember the body mass index, right? Now, what is the formula for mean arterial pressure? It is always 2 multiplied to diastolic blood pressure plus systolic blood pressure divided by 3. Whatever value you will get with this, that will be your mean arterial pressure. Always remember, mean arterial pressure, if it is less than 60, then it requires immediate intervention. The normal should be 70 to 100 millimeter of mercury. How you will calculate cerebral perfusion pressure? You need mean arterial pressure and intracranial pressure, right? What is the normal intracranial pressure? 10 to 20 millimeter of mercury is normal intracranial pressure, right? How you have to convert the degree Celsius and Fahrenheit? Only one formula you will remember. So degree Celsius is equal to Fahrenheit minus 32 multiplied by 5/9. With this formula you can calculate the temperature conversion, right? Next is the adventitious breath sound. Under this, the most common is absent breath sound in pneumothorax. Frequently asked. Pneumothorax, you have to by heart, you have to remember this. So under pneumothorax, what are the important points? Number 1, it has absent breath sound. Absent breath sound. Second important point is in case of tension pneumothorax, we can have mediastinal shift. Mediastinal shift or tracheal deviation. We can say tracheal deviation that can occur on unaffected side, not on the affected side. right? So we have crackle. You can see, you can auscultate crackle where there's a case of overload, fluid volume overload, like pulmonary edema, COPD, pneumonia. Wheezing is best for asthma. Then rhonchi, when the airway is having obstruction filled with secretion. For example, COPD, pneumonia के cases में you can have bronchi. Then stridor is an emergency. Question can be asked you that in which of the following breath sound you have to immediately inform to the doctor. Stridor, because it indicate airway obstruction, upper airway obstruction. Pleural frictional rub, when you have insufficient we have when you have insufficient fluid in between the pleural layer, the visceral and the parietal, we can have in pleural frictional rub, right? That can be seen in case of pleurisy or pneumothorax when it is filled with air, or when you have excessive water as well, then you can also see, because water will settle down on the lower area, so then also you can have pleural frictional rub. So yes, that's all from my side. That is all the volatile topic in one liner form. And this is, again, let me tell you, this is just your last minute revision video. Do not take it in a very conceptual way, because our purpose is to quickly revise the volatile topic. So I hope the session is beneficial for you all, and will this all the very best for your NORCET entrance examination, and I'm sure you will do your best. Till then, stay happy and stay healthy.